YSU paramedic program in '07. This is my white coat. I took a picture of it. It was still in my parents' house. Took a picture of that the other day. After I left YSU, I went to Columbus State Community College here in Columbus and got an associate's in respiratory care in 2010. And then I've been an EMS instructor since 2018. I finally finished my bachelor's in emergency medical care from Eastern Kentucky in 2019, and minored in psychology, which means I have just enough info on psychology to be dangerous. And then I've been with Delaware County EMS since 2008. I've been a captain with them since 2019. My primary role there is I'm in charge of our clinical quality improvement program. So a lot of patient care and fun stuff like that. So we're going to talk about capnography. Like I said, with my role as a respiratory therapist, I get a lot of exposure to this, and we have a lot of fun with it. And it's a fantastic tool. It's non-invasive, a lot of great things that we can do with it. So I want to show you all the benefits of it. A little bit of history. John Scott Haldane, who is a Scottish physician, they think he built the first CO2 analyzer back in the mid 20th century. It really didn't become popular in the U.S. until '78. Used a lot with anesthesia patients. Had a big use in. It's had a big use. Still does have a big use in like sleep medicine and measuring people for sleep apnea. But then it first got into the literature for EMS and came into PE, pre-hospital emergency care, the journal, in about 2001. And really that article really started off the path for bringing end-tidal CO2 into what it is today. So a couple things, there are some current standards regarding end-tidal CO2, and these things are into law. And as of the first of this year, any patient with an invasive airway device must be monitored via end-tidal CO2. And the state defines that as an endotracheal tube, an eye gel, so subglottic, supraglottic airway, an LMA or a dual lumen airway, whether it be a combi or king, basically any kind of invasive airway that's the sole purpose of it is to provide ventilations. We want to make sure that we have that, and so the state has now mandated that we're going to use that. Now, does this mean those purple to yellow color changing off to the right? Unfortunately, that does not. These guys are far too.
I don't know if he's driving. Oh, that's
sensitive.
Matt Warshuk.
Oh, okay.
And so it's kind of difficult to really understand if we're maintaining an endotracheal tube. So this has to be waveform, capnography, and capnometry. So a little bit about how end-tidal CO2 works. There's kind of two different versions of it. So there's mainstream devices and then side stream devices. Both give us results within a matter of seconds. And as you see here with this graphic, whether it be the patient breathing spontaneously or they're on an endotracheal tube or some other kind of airway, gas goes past this infrared source, and then the machine monitors it, and that produces that waveform, as you can kind of see. Now, on the left here, this is your mainstream capnography, where all that is done right there. It has its benefits of it. It happens right there. The downfall is some of the equipment's a little expensive and can be broken very easily, which is not great for the EMS world. Whereas, and another thing, it kind of takes a few minutes to heat up and warm up. So good for anesthesia or like long-term in like the ICU, but not great for EMS world. What's most popular in the EMS world, and really starting to become most popular anywhere in healthcare, is side stream capnography. The pieces are cheap. The product works quickly. So, and there's really minimal difference between the two. In this, there is, as you see here, carbon dioxide comes out of the body, comes through here, and an adapter will sample a little tiny bit of it and pull it into the machine and analyze it and give you that waveform and that number. So that's the beauty of mainstream versus side stream. Like I said, a lot of places are going to side stream capnography, and it gives you results really quickly and gives you a good result of what is going on. If you want to get into really into the nuts and bolts of it, this picture kind of shows that infrared light, and as that infrared light is deflected by the different CO2 molecules, the sensor on the other side picks up the amount or the lack thereof of CO2 and then produces the waveform. obviously less CO2, more light waves come through and get picked up, and a smaller waveform of capnography, a smaller reading of capnography, versus a lot of CO2, the light waves get deflected, don't get picked up on the other end, so that it equals a much higher level of CO2. All right, so this is going to be the tough part. So we're going to have to, because part of this, I had plans to actually like draw on the board. I wanted to go full Joe Mistovich style and draw on the board and make you understand, but had some technical difficulties. So please forgive me, guys. Think about why end-tidal CO2 works. It's a great representation, and it's really more of a cycle where you have ventilation, and then that's affected by the circulation, which is affected by the cellular respiration, most commonly thought of as the Krebs cycle inside the cells. But then circulation facilitates the CO2 going back to the lungs, and ventilation then further blows it off. So the nice part is all of these different things together can be represented by your end-tidal CO2 waveforms. So keep that in mind as we go forward. Our normal values, 35 to 45 millimeters of mercury. Remember that this demonstrates a concentration or amount of end-tidal CO2 that's being blown off by the patient. It's not really a reliable representation of volume. Volume, it's just not a good way to measure volume. So don't equate that just because they have a high level of end-tidal CO2, that means that they're blowing off a ton of volume and moving air in and out of their lungs. It just may mean something else. And we'll kind of get into what the differences are here. Okay, so I want to get into what our waveform is. So as you see, you have your expiratory upstroke. So so here, can everybody see my mouse? I hope. Here's your inspiratory waveform, or inspiratory baseline. So this is when the patient is breathing in. And so when you think about what end-tidal CO2 is measuring, it's measuring the CO2 that's going through the sensor. When we breathe in, there is no CO2, practically no CO2 in the ambient air that we're breathing in. So that level is going to be 0. As we start to exhale, keep in mind, if you remember from our pathophysiology classes, that the initial amount of air that we breathe out has only come in contact with the physiological dead space. So basically anywhere in the lungs that is not the alveoli. So the initial levels on this expiratory upstroke, as the patient is just starting to breathe out, do not have a ton of CO2, but it's building quickly. So then comes this expiratory plateau, and this is the part where we're really seeing the carbon dioxide that's been exchanged in the lungs and is starting to get blown off into the ambient air. And then right here, this end expiration point, that is your EtCO2 number. So end tidal referring to a breath, and then carbon dioxide. And then you have an inspiratory downstroke as the patient begins to breathe in. So the amount of CO2 as the patient breathes in is going to plummet because there is no CO2 out in the ambient air or whatever air you're providing to them. So it plummets down. All right. So there's a couple different waveforms, and I'm actually going to try something really quick. Guys, I'm sorry, I'm striking out today. We'll get it figured out one of these minutes. Okay. So some of the waveforms, I'm going to try and figure out. So hypoventilation, what we'll see with that waveform is slowly increasing levels of CO2. And you won't necessarily see it in a single waveform. What you will see it is over time, okay? You'll also see the waveforms getting longer, okay? So this is as the patient is breathing out, they're spending more time exhaling, and they're also breathing off more CO2 because they're ventilating slowly and they're otherwise not able to blow it off. Okay, so hypoventilation, you'll start seeing longer boxes, you'll start seeing taller boxes, your numbers will increase. It's a good sign that the patient isn't adequately ventilating. Okay. Okay. All right. And then hyperventilation, we're going to see smaller boxes that will gradually get shorter. And the reason that's happening is you'll see these pretty quick too. So the patient's breathing pretty quick. The amount of carbon dioxide that is coming off with each breath is decreasing pretty rapidly. The reason for this is because the cells only produce so much. The heart can only bring back so much of that CO2 from the cells so quickly, and so the amount of CO2 actually being blown off continues to decrease. Next is I'm going to stay away from breathing for a second, and then talking. If the patient's talking, you may see all kinds of stuff. So sometimes you may just have to tell the patient to stop talking for a second if you need to see what their end-tidal CO2 waveform is. Another waveform you may see is called a shark fin. And that looks something kind of like this, which is a stark contrast from the standard end-tidal CO2 box waveform. We see the shark fin most commonly with our bronchospasm patients. And ultimately what's happening, like we talked about with physiological dead space, is it's taking, because the airways are so clamped down, it's taking a long time for that CO2 from their alveoli to actually reach their mouth and be blown off into the CO2 sensor. So that's why we get this shark fin. Okay. And then finally, occlusion. I want to cover what occlusion looks like on your waveforms really quick. And what we know about occlusion is that the waveform will look like this. And it will tell you with a dashed line that you have some sort of blockage, okay? That's important because in contrast to a flat line, which means absolutely no ventilation whatsoever, some may say, oh, it's blocked, it's occluded. No, that's blocked, occluded, and that's actually apnea, and that's going to kill your patient. So we have to be mindful of that for sure. Okay. Okay. So decreases in end-tidal CO2 can happen for a variety of reasons. We'll break down some of the different reasons, going down through different airway issues, pulmonary transport, or cardiovascular reasons, and then issues at the actual level of the cell. So airway, if they have bronchospasm, they may have a decreased end-tidal CO2 simply because they're breathing so fast. And like I said, with this, you see that shark fin waveform, that they're trying really hard to blow off CO2, but because of the airway restriction, they simply can't. There's simply no pathway for it to get out of the lungs and into the ambient air. So you may see some decreased end-tidal CO2 levels along with your bronchospasm. These patients need some sort of serious support. They need bronchodilators. They need steroids very fast. Other reasons for decreased end-tidal CO2. From the pulmonary side of things, it could be something like CHF. So one thing that's kind of interesting about end-tidal CO2 is if they have fluid in their lungs, that prohibits oxygen from getting from the alveoli into the bloodstream, but it does not necessarily prevent CO2 from getting out. So the patient's breathing really fast. They may have problems getting oxygen in, but they will sometimes have decreased end-tidal CO2s with that. Addition to that, think about the heart and we'll get into this with transport, but think about the struggles that the heart is going through. If the heart isn't able to effectively pump blood around because of heart failure, then they're going to be struggling to return CO2 from the cells back to the lungs where it can be blown off. Another reason for decreased end-tidal CO2 that we'll get into is compensation for metabolic issues. So sepsis and DKA specifically come to mind. And this is strictly compensation. And we'll talk about why the pH is important here a little bit later. The next thing is transport. So your cardiovascular system. If you start seeing a trend of decreased end-tidal CO2s and your patient keeps looking sick, be ready for some sort of pending, or maybe they had active decompensation. This could be cardiac in nature. This could be trauma in nature. And I want to flip over to my other presentation really quick to kind of speak more about this. So with end-tidal CO2, there's actually some pretty good research out there that shows that traditional vital signs paired with end-tidal CO2 can be really helpful for helping us predict pending shock and cardiac arrest. So this paper was published in Resuscitation just a few years ago, and what they looked at was patients that were transported by Air Methods, the helicopter vendor, for a little over 7 months. They were all greater than 14 years old. And they had a variety of issues, whether it be sepsis or hemorrhage, congestive heart failure, massive PE. They were all in there. A majority of the patients in this study had a traumatic mechanism, so a lot of hypovolemic type shock, and a lot of them were receiving some sort of positive pressure ventilation prior to their arrest. So we can expect that these patients were probably pretty sick. So what they found, looking at their vital signs based on their vital signs that they recorded and then compared them to the time that they actually arrested, they looked at what the heart rate did in those kind of situations. And what they found was that the inflection time, or the time where it basically bottoms out prior to them arresting, was about 2 minutes. Okay. So that's this green line here. You can kind of see that the typical trends of the heart rates of these patients, and towards the end, towards when they arrest here at this time 0, that's when it kind of drops off. But these outer lines show basically where everybody else kind of lied. So heart rate in these patients varied anywhere, 95% of the patients, it varied anywhere from 70 all the way up to like 110. And then it kind of followed this trend. But then towards the end, you can see that some people's heart rates skyrocketed. Some people's heart rates just completely braided down. So heart rate wasn't a great predictor of arrest in this situation. The next thing they looked at was systolic blood pressure. And so with this, a little bit better of a time. So about 4 minutes, they found that at 80 a blood pressure of 80 systolic around was about a 4-minute warning to show that the patient was about to go into arrest. And this was pretty consistent as you see all the lines kind of follow together, and then it all just eventually bottoms out. But as you see here at the bottom, we know this. We've all, for those of you that have listened to Joe's trauma pathophysiology, we know what happens. So, but end-tidal CO2 kind of does something better. So as you see here, while the values kind of start anywhere from 20 up to 60, and typically in that 40 range, they all kind of come together here. And then at about 5 minutes is where they determined that inflection point was. And they found that if you're starting to trend down, once you get to about 24 on your end-tidal CO2, that's when you start to drop off, and you're about 5 minutes away from an arrest. So end-tidal CO2 is a fantastic predictor of your patients that are about to code for a variety of reasons. So this really kind of helps emphasize the point that this is a valuable use for any patient that may be sick. Okay. All right, other reasons why we can have decreased end-tidal CO2, pulmonary embolism, and then finally at the cellular level, one big reason is hypoxia. And so if you remember there is aerobic and anaerobic metabolism. If the cells, simply put, if the cells don't get oxygen, then they're not going to produce carbon dioxide. Instead, they're going to produce lactic acid. And so if you have a decrease in those, in your end-tidal CO2 returning to you, that could be because that the cells aren't actually producing CO2, they're producing lactic acid because they're not getting any oxygen. You're going to probably see some other much more larger signs prior to that point, but that's a good indication of that. Okay, reasons for increased end-tidal CO2. One of the biggest ones at the cellular level is increased cellular metabolism. So patients that may have, you see it sometimes with patients who like just worked out and they just maybe are having some anxiety, and so they'll have some increased cellular metabolism, not super common. Other things that we'll see from the cardiovascular side of things, this is a great predictor of ROSC. So you're working at cardiac arrest, you have end-tidal CO2 hooked up, you're doing compressions, and suddenly you see a spike. And it's usually not a small spike. It's usually a spike of about 20 points. And that could be a good indication of that you've achieved ROSC. Now, of course, we want to continue CPR for the 2 minutes that you're doing it, but this can be a good indication that you may have had a rhythm change into something perfusing during a cardiac arrest situation. And of course, another reason for increased end-tidal CO2, anytime there is decreased gas exchange at the level of the alveoli. So, like we talked about, if they have, say, pneumonia or some kind of alveolar breakdown, the alveoli are collapsed, whether it be a traumatic etiology or it could be like pneumonia, COPD, take your pick. A lot of times the gas can't leave the alveoli from the bloodstream. The gas can't get out, so it remains in the bloodstream until it can get to an alveoli that's actually functioning, and then it will leave. So will all the other carbon dioxide that would normally go through this. And so you get an increased end-tidal CO2 level as that all builds up in the bloodstream. All right, so you may be asking, why is my cat on here? That's because his name is PH, long story. But what matters with end-tidal CO2, and what's really important about end-tidal CO2 is its effect on acid-base balance of the body. Does the body care about your CO2 levels? No, actually it doesn't. Your body cares about the pH inside of it. So if the blood pH is off, really nothing else matters, and the body is going to try and adjust for that. One of the primary ways that it can do that is to make the patient breathe faster or deeper. When it does that, that is probably one of the most that's a primary way for the body to compensate and get rid of some of that extra CO2 and try and reduce the pH back into, or I'm sorry, bring up the pH into a normal level. Another thing I want to bring up is the oxyhemoglobin dissociation curve. If you remember John Scott Haldane, this is called the Haldane effect. And what the oxyhemoglobin dissociation curve kind of shows is that when your pH is off, it's outside of that 735 to 745 range. When it's off, it affects how well the hemoglobin can either pick up or let go of oxygen. So if your patient is acidotic, so their pH is less than 735, that actually sometimes prevents most of the time will prevent the hemoglobin from picking up oxygen as it goes past the lungs. So that's a big problem. But you'll see that as well with your SpO2. Another situation in a time where we as healthcare workers may have been killing our patients is the other side of the oxyhemoglobin dissociation curve, where the pH is actually too high or the patient is alkalotic. When the patient's and the blood is alkalotic, the hemoglobin will pick up oxygen, but it doesn't want to let go of it. So as the oxygen attached to the hemoglobin goes past a cell somewhere, it won't let go. So the cell continues to go into that anaerobic metabolism, not because there's not enough oxygen in the blood, but because the oxygen won't let go from the hemoglobin. So keeping that blood pH 735 to 745 in that range is really important to the body. And so it tends to put preference on there, and it tries to adjust as much as possible to keep it in that range. And it's going to adjust the carbon dioxide as its primary system to try and buffer it in order to try and keep things under control. So. Couple last things with end-tidal CO2. There's dislodgement, there's obstruction, pneumothorax, equipment failure, the dope mnemonic. This is something we use a lot when we're looking at our end-tidal CO2 and things are off. When your patient is tubed, when your patient is on end-tidal CO2, and you start noticing that flat line like we see here, we need to go to that dope mnemonic and see if either our tube is dislodged, obstructed of some kind, patient has a pneumothorax, and then we get into something like equipment failure or something like that. If your patient isn't tubed and they're spontaneously breathing, and we see this flat line, we need to assume they're not breathing and we need to breathe for them. So this right here is a shot of a rhythm strip and an end-tidal CO2 waveform here at the bottom of a patient that they thought was intubated, and it was not. And as you see, they're starting to slowly Brady down, and their EKG waveform is looking pretty terrible. So, okay. I want to flip over to my other Capno presentation just really quick. And I want to get into some other uses of end-tidal CO2 beyond just what we use for respiratory stuff. So let's talk sepsis. In sepsis, we have the massive vasodilation, we have the leakage of fluid out of the cells and out of the capillaries, and that leads to a decreased amount of oxygen to the cells. With that, because the cells aren't getting oxygen, they're producing lactate rather than producing carbon dioxide. So our O2 is dropping, our lactate is increasing. That increased lactate is causing the pH to drop down below and causing the patient to become acidotic. So the body tries to compensate by breathing faster and blowing off that end-tidal CO2. and you'll see that the amount of CO2 in the blood as well as the end-tidal CO2 will decrease, and the heart rate will start to increase as well, because that's what the body does. It just increases the heart rate to try and compensate every time. And then you'll see, like I said, the respiratory rate jump up as a means to blow off extra CO2. And so that's pretty common with sepsis. The big thing to take away from this is, I think we're seeing a lot of this with every patient now, we're checking temperatures, and that was something that we didn't always do with our septic patients or with any patient. So the telltale sign for this will be temperature. So kind of when you put it all together, this is what kind of your sepsis patient looks like. And the cool thing is we can attach them to end-tidal CO2. And as we see, a very short box, a lot of boxes showing that the patient is breathing fast. Their blood pressure doesn't look good. They're tachycardic. This is a septic patient that needs some fluid resuscitation, if not some pressors. All right, so I mentioned earlier diabetic ketoacidosis. I want to talk about why end-tidal CO2 matters with diabetic ketoacidosis. So in this situation, we really don't have a problem with oxygen getting to the cells. There really is no etiology, there is no pathology that's causing a decrease of oxygen going to the cells. What we are getting is because the cells aren't, because sugar isn't going into the cells because insulin isn't there isn't enough insulin, or the insulin isn't working, the cells are starting to produce ketones, okay? Ketones are acidotic, and so that will drive your pH down, cause you to become more acidotic. As a means to compensate, because the body only cares about pH, it will it'll want to drop your PCO2, which will drop your end-tidal CO2. Your heart rate will increase a little bit, but the big thing is your respiratory rate will increase a lot. So you'll see these patients breathing fast. This is those Kussmaul respirations. Probably the lowest I've ever seen is an awake lady with a sugar in like the 700 or 800s on an insulin drip that was breathing like almost 30, 32 times a minute and an end-tidal CO2 of 9. So that's how hard she was trying to compensate. And again, this is the body's efforts to try and regulate the pH and keep that oxygen going. But oftentimes it's not enough. So temp for these patients, typically nothing exciting. Talked about that. So, at this point, I'm going to do a Q&A session, and I want to hear what you guys have to ask. Any questions? I want to know, like, are you guys using it out in the field? Are you enjoying it? Is it serving you well? Please, any questions you guys have? I am all ears.
Hey, Glenn, it's Matt, and I would say that probably 90% of us have end-tidal CO2 monitoring, and in fact, it's required for most protocols up here. It may even be. Is it required in the state now?
Yeah.
I believe it's required in the state under the state regulations now too.
Right.
But I did like the tips on the sepsis. I like that.
Yeah, it's pretty crazy that we're able to pick up on all these different things with something that's traditionally been known as a respiratory vital sign. So it's really helpful for all these different other things. We put it on if we think they're a septic patient, that's part of our documentation. If we think they're DKA, end-tidal CO2, part of their documentation, and we're starting to do it a lot more with trauma. If of course, if your trauma patient's really sick, they're often going to be getting intubated anyway, so we're going to have end-tidal CO2 with that. But it's a fantastic predictor of those patients that may start to be, hypovolemic and start to crash on you. So.
Glenn, here at Trumbull, under our protocol, we actually use it for any time we give sedation medication, so Versed ketamine and fentanyl, and it's actually required. So, even though we're not giving them oxygen, we're monitoring them. And especially with the recent events with Colorado and everybody else making a big deal about giving ketamine for excited delirium, we've emphasized through education, and we've even put it in writing and with red exclamation points for a 2022 protocol, is if you're giving ketamine, if you're using fentanyl, your airway kit probably should be open and right next to you. Because that's how we practice good medicine while observing the patients. And the pulse ox is a poor indicator. So when you look at the capnography, you're able to see their breathing rates and see how well they're breathing. So that's actually, we've implemented more than just an invasive airway. We're doing it with, pain medication, and anytime we got to sedate somebody. So that's I think where we're going to go in the future with the whole state.
Yeah, while it's unfortunate the situation out in Colorado, I think it does shed light on just how important this is to monitoring our patients' breathing, especially when we're giving something high potency like ketamine. So I'm really glad to hear that you guys are doing that. That's awesome.
Hey, Glenn, it's Joe. I just want to make a point too, is to reinforce that capnography is an indication of ventilation, not oxygenation. Or, some people want to think that, the capnography is an indication of how well the patient's being oxygenated, and it's not. I mean, for us in EMS, it's really the SpO2 that's going to give us, the best indication, I think, that we have available in the field to oxygenation. But, the capnography is truly a diagnostic tool, and it's a great tool, as you pointed out, indicating how well the patient is ventilating and not oxygenating. We covered that the other day on Tuesday, and the only way to get rid of the CO2 is through effective ventilation too. So so therefore, again, the CO2 production and the CO2 waveform is a good indication of the ventilatory status, but not the oxygenation status. And I think that's key, even with the COVID patients, especially, because it's saying, they truly have an oxygenation issue, and it's not necessarily a ventilation issue, but it's an oxygenation issue. So just keep that in mind, that when you're using the capnography, just be sure that you're using it for the right reasons. That's all. So, yeah, good points. Yeah, I like the sepsis thing too. Also, the prediction on the trauma patient. I've never seen that before. That was very, very interesting. Thank you.
Did I teach Joe Mistovich something? My work here is done. Okay.
You better write that day down in a notebook and frame it.
I am. I'm gonna just circle it in red this day.
Hey, Glenn, it's Justin. Good presentation, buddy. One of the other things that we have actually been using Entitled for, especially on the flight side, is we are giving sucks to our patients in the field, which, as you know, is kind of a roll of the dice with a lot of things when you don't have a lot of history on them. And that's actually been a great indicator of early malignant hyperthermia for us. So if your patient has received sucks, Entitled CO2 has been great for that. The other thing it's been great for us is when we're starting blood transfusions on our trauma patients, that's usually one of the earliest signs in the aircraft we'll see with a hypersensitivity reaction or a blood transfusion reaction, because as that metabolic rate starts to ramp up as a response to the blood, that's one of the first things we'll see ever before an indication of heart rate increase, temperature increase. We'll usually see a spike in their end tidal with a adverse blood transfusion.
That's really cool, and I'm going to add that to my presentation if you don't mind, because that's something that's something we never really thought of, and I think that would be even useful in the hospital to use. So thanks for bringing that up.
Yeah, that's something our trauma surgeons brought up to us. They said if you got somebody that's sitting in the mid-20s and you spike to 40, just expect a massive transfusion reaction. Stop it. Start your treatment, because you're going to see the clinical signs and symptoms pretty quick after.
Okay. So I guess because my question would be, is it necessarily an indication of like a transfusion reaction, or is it just now they have the volume to circulate the CO2 around and blow it off?
A lot of times, if you see a rapid spike, if you see a general upward trend, that's volume replacement. When we see an immediate spike within, they said usually within the first 5 minutes of transfusion. If you see an increase after that, it's unlikely to be that rapid of a transfusion reaction. But as soon as we're starting our first unit of pack cells, because we start with plasma, then we go pack cells, and as soon as those red blood cells hit, if it spikes immediately, then we know we have a transfusion reaction likely on our hands, and we're going to stop and go to our alternate treatment.
Gotcha.
Has anybody seen in real life who's on this chat, like the capnography of the ROSC and how it jumped up, like Glenn said? And did you see it on your monitor? And, were you able to, interpret that?
Larry, this is Roman. Yeah, I saw that on the cardiac arrest going in and out of ROSC a couple times. It would jump up when he got ROSC as soon as he lost, as soon as decrease in title, and lost it right away again. So it was back and forth a couple times.
Roman, how you doing, man?
All right, how about you?
Good. It's been a while.
Yes, it has.
Anybody else have an experience with the capnography? Pros and cons?
One thing I'll throw in there too, as far as is with cardiac arrest, is there's a lot of benefit with using capnography as a means to tell how effective your compressions are. It's not perfect. The research says it's not as good as the automatic CPR feedback that you get, like specifically from Zoll and Zoll, Physio, and then Tempest all have have the CPR feedback. But if you're in a system that maybe doesn't have that technology quite yet, you can still use end-tidal CO2 kind of as a means, and you'll see a general trend upward, just showing that you're starting to circulate that volume around. You're starting to get CO2 from the cells, which means the cells are getting oxygen. So that's another kind of use you can use it for.
Hey, it's Ralph. I've seen it a few times in the field. Return a ROSC, and then you have a rhythm, and we're unsure if it's PEA or not because we can't palp a pulse. So back then we hung dopamine, bumped them up. We got pulses, palpable pulses, so it worked out pretty good.
Yeah, that's an excellent indicator. Like you said, is it PEA or is it a perfusing rhythm with a low pulse? And you would know that if it's a perfusing rhythm, you should see that bump in tidal, so getting off all that waste. So that's an excellent thing. Anybody guide their treatments with the shark fin? Somebody is short of breath, you can't determine, they're so constricted, you can't really hear any wheezes or rhonchi or anything, but maybe you see the shark fin, so you kind of lean towards COPD asthma versus CHF and pneumonia, and then you're like, hey, I see this, so therefore I need to give some duonebs or anything like that, because that's a key indicator too. Okay, well, I mean, if that's the case, so I think what we'll do is, we'll go ahead and take attendance by you raising your hand. This is a good time to, I think, take a break and prepare for the next lecture. So everybody, just go ahead and raise your hand in the thing. We'll go ahead and see your name, and then we'll put them down. And I would say come back here right around 7 o'clock. They'll give you a little bit of an 8-minute break or so, and we'll continue on with the next lecture. Pitch it back to Captain Glenn Keating here, and he's going to talk about some airway techniques for all providers from EMR all the way up to paramedic. to continue on with our kind of our Airway series here. So Glenn, back to you.
Thank you much. This is my big Airway presentation, but I'm going to kind of trim it down just a little bit, and we're going to give you guys kind of the nitty gritty and the really good stuff rather than like I said, I trust Joe Mistovich to have taught you all the great pathophysiology stuff. So, you know, we'll start off where he we'll start where he left off. So, this was part of the presentation, but everybody loves a guy crashing a scooter, so I figure I'd let that run for a hot second. You know, when we're talking about Airway, I think a big thing is think about, before we start diving into our invasive procedures, make sure we're thinking about our non-invasive procedures. So always think about things like CPAP when your patient's having difficulty breathing. Great tool. Long term, it's a great option for our patients. We see a lot of times in the ER where patients will get brought in on CPAP. They will we'll continue them on CPAP for a couple hours. They'll go to an observation floor and get turned around and likely get discharged late the next day, if not later the same day. So it's a helpful thing. With the emergence of COVID, for a while we were kind of staying away from CPAP, assuming that if they were sick enough for CPAP, they would likely just need a tube anyway. And that's kind of turned out to not be true. So continue to using CPAP even with your potential COVID patients. Just make sure that you're doing stuff to protect yourself, so that way you don't possibly get it. When we do CPAP, that obviously increases the amount of aerosolized particles that will come from the patient. There isn't a great way to filter CPAP, any of the CPAPs that are out there, unless you're getting to kind of the more expensive hospital-based systems or some of the more expensive flight systems. So just make sure that you're taking care of yourself. So when we're doing CPAP, you know, this is for anybody that's really in respiratory failure, where there's a issue with gas exchange functions. It's a step between the standard O2 therapy and endotracheal intubation. If the patient has a GCS greater than 8, they're okay for CPAP. They have to be awake for this. And like we said, it improves gas exchange, so keeps alveoli open, and then tries to recruit additional collapsed alveoli, and will typically reduce their hospitalization. So as you see, as air goes in, it kind of pushes the airways open, and that makes a much larger highway for gas to go in, i.e. oxygen, medication, breathing treatment, stuff like that. And then also on the flip side, allows the airways to stay open and allows for gas to leave, your carbon dioxide. So really, CPAP is indicated for all of these things. Pneumonia and asthma, I put that at an asterisk there because for a while, you know, we were told it wasn't a good idea to give these patients CPAP. Give these patients CPAP. Combine it with your breathing treatments, so your albuterol and your Atrovent, to try and open up those airways, but it is safe to give it in those situations. Your absolute contraindications for CPAP: respiratory arrest or agonal respirations. Obviously, these patients need ventilated. If they're unconscious, they can't protect their airway. You give them CPAP, they're going to aspirate and they're going to get an aspiration pneumonia. That's typically lethal. So any sort of shock associated with cardiac insufficiency. So keep that in mind. And then any sort of like facial abnormalities, like your burns, fractures, things like that. If they have a pneumothorax, obviously the last thing we want to do is shove more air down there. If they're actively vomiting, that kind of goes with unconscious. That's assumed that they're going to aspirate and have it become create an aspiration pneumonia. And then, of course, if they have a trach, we really can't put them on CPAP because, as we all know, air follows the pathway of least resistance. So through the mouth and then back out that trach, not to the lungs where we want it to go. If your patient has a trach and they need something like CPAP, perfectly safe to pop the BVM onto them and just help ventilate them. So some relative contraindications: be careful if they have a GCS less than 15, if they have some claustrophobia. A lot of patients, though, we had a really good case at our agency here recently where a patient had claustrophobia, but the team did a fantastic job just coaching them down because they really weren't eligible for any sort of sedation to try and settle them down either. And then also be on the lookout for any kind of upper GI bleeding or recent abdominal surgery. With CPAP, you tend to get a little bit of extra air going into the belly. So just be mindful of that. Not an absolute contraindication, but just something to be aware of. So that's because one of the big hazards is gastric distension. Gastric distension happens when there's extra pressure, about 19 centimeters of water. So most CPAPs, especially in the pre-hospital setting, don't go above 10. But just to be safe, just something to keep in mind. One thing that can happen sometimes is hypotension associated with CPAP or BiPAP. I'll be honest, that is a thing that people worry about, but we rarely ever see it. We really only see it in like our ventilated patients, and we're using extremely high pressures in those situations. So be mindful of that. If they're already hypotensive, like say they're a CHFer and they're already hypotensive and we won't put CPAP on them, be thinking that we need to do some other stuff, whether it be dopamine drip, epi drip, push doses, whatever you have at your disposal, keep that in mind. And then, of course, it can cause pneumothorax. That's less than 7% of all patients that it can cause pneumothorax, but something still that we should definitely keep in mind. And it's quick and easy to check for by listening to lung sounds. And we're going to listen to lung sounds anyway, right? So patients in respiratory failure respond best to CPAP when used with other therapies. If it's CHF, it means we need to give them some nitro to help open up their blood vessels. If it's something like asthma or COPD, we need to give them those albuterol and Atrovent treatments and keep giving them. So continuously monitoring them, put your patients on end-tidal CO2. Great choice. But then also keep in mind, keep them on SpO2 as well. They may be able to ventilate okay, but they still might not be getting enough oxygen to their cells, and they could start becoming hypoxic, and that may be an indication that we need to go into more invasive measures. Watch their chest, and if you're considering using CPAP, you should. One big thing, kind of a pet peeve of mine, if you're coming from the field with a patient on CPAP and you're calling into the ED, please try and call in to us with a ETA of 10 minutes or greater. Just makes our life so much simple, especially in this world of COVID right now where we're all stretched very thin. We want to continue that CPAP. We know how important it is. Give us a few extra minutes to try and get down there with the machine, find a machine and get down there with one to get you guys transferred over. So we should discontinue it if we start seeing increasing end-tidal CO2 levels. If the patient isn't tolerating it, they start vomiting, hypoxia like we talked about. If they're starting to show signs that they're getting exhausted, we need to move on to something more invasive. Same thing with if they start to maintain their consciousness. And if the other thing is if they start making marked improvements and they're back to where they should be and maybe they don't need it, yeah, you could discontinue that as well. So if for whatever reason we have to discontinue it, reassess the need for ventilatory support, consider BVM and some sort of sedation or RSI, and then just make sure that we're documenting it. So this is our device that we have at our agency. There are tons and tons of devices out there for pre-hospital CPAP, but you see it's kind of nice. It's a single line in here that delivers extra air to the patient's face. It's a mixture of oxygen and room air. And then down here, it's got a place where we can plug in a nebulizer, which is fantastic to deliver those nebs to those patients that need it. So, okay, so I want to get into a little bit more about some airway stuff. And a lot of what our airway management is nowadays is no longer getting the tube. I'm going to say this again, and I hopefully some people don't throw a pitchfork at me, but what we don't want to necessarily focus on is getting the tube. Instead, we want to try and avoid these three things, the H bombs of airway management, okay? And that is hyperventilation, hypoxia, and hypotension. And what we've learned is that when we avoid those things, we have a significant improvement in our patients' outcomes. They do better, less chances of them coding secondary to our medication or our procedures that we're doing, whether it be medications to sedate them and then paralyze them, or even inserting a tube. All these things can lead to them, potentially lead to the patient's, lead to cardiovascular collapse and can cause them to code. So this was a study out of Arizona where they looked at TBI. It's called the EPIC study. They looked at TBI patients that got intubated, and they looked at and said that survival doubled among patients with severe TBI and tripled in patients with severe TBI who received intubation. But that was all secondary to preventing hypotension, preventing hyperventilation, and preventing hypoxia through the entire procedure. So, if you want to do some research of your own online, look up Vanderbilt Emergency Medicine. They have a fantastic series of videos out there, and they talk about how they train their their emergency medicine residents. And they start with 5 core airway skills. And these are a lot of things that we talk about with our people, my agency as well. First one is you can't truly manage an airway unless you're an expert at doing BBM, okay? And this is fantastic because every level of pre-hospital provider has a BBM, can use a BBM at their disposal. As we said, getting the tube necessarily isn't the primary outcome that we're going for. What we want to do is prevent hypoxia, and you can do that with a BBM. So the other core airway skills, direct laryngoscopy, video laryngoscopy, supraglottic airway, and then surgical airway if you need to. Another fun thing about the supraglottic airway is both AEMTs and paramedics can insert it for anybody. And then EMTs can insert it for any patient that's pulseless and apneic. So if you're a double EMT system working a cardiac arrest, one person can start in compressions, the other person can drop in like a supraglottic airway, like an iGel, and begin ventilating the patient, and do all that pretty quick without risking any sort of hypotension or hypoventilation or hypoxia to the patient. So we said expert BBM. We're really big about two-handed technique on the mask. So 2 hands on the mask, keeping a good hold of the jaw like you see he's doing with his lower fingers. So if you have the people to do this, and I understand that in the EMS world, sometimes we just don't have the people. But if you have the extra people to do this, where one person can hold the mask on the patient's face and get a good seal while the other person squeezes the bagging and kind of keeps a good focus on that, that's really what expert BBM is. You know, positioning the patient is really important for when we're trying to intubate the patient, but it's also super important for when we're just trying to do a BBM. And this is a good example of kind of the intersternal notch, or aligning all the different axes of the airway. And as you see, just the patient laying supine, all the different axes are kind of all off in different directions. But if we can kind of stick something under their head, tilt their head back, we can do a good job of aligning those axes, and that provides a direct line for that air to go from that BBM into their lungs. As you see here, there's a couple different options here as far as how to deliver BBM with 2 people. You see on the left, they've got their hands under the jaw and the other fingers really pushing tight on that mask. The other option, as you see, they have more fingers underneath the jaw, and then they're kind of using their thumbs and the muscle of their thumbs to push that mask against their face. So what do we do about beard? So if you're having trouble with a bearded patient, a fun thing you could do, I shouldn't say fun, a useful thing you can do, which is kind of funny, is that you can take a tegaderm and actually put it over top of their beard. And that will help create a better seal while allowing you to still ventilate them. Obviously, you don't want to take that tegaderm and put that over their mouth. That would be completely counterproductive. But this at least allows you some kind of a solid interface between the beard and the mask. So you're not blowing air through the beard, you're actually going to blow it into their lungs. So what's kind of interesting, this is more just funny, I think. This was a picture off of a safety and supply, an industrial safety and supply company website where you can get your very own bag mask resuscitator, but just please don't use it in the fashion that they're using it here. So. Some equipment with this here recently with COVID, obviously there's been a huge influx with the need for filters. So even if you're doing just standard BBM with a mask and a BBM, make sure you're putting a filter in place to try and prevent any sort of spread of some kind of particles. I've kind of turned into a germ freak over the years, and so I'm more apt to put on a filter regardless of whether or not it's COVID or not. I want to talk a little bit about PEEP. And so PEEP is a nice, useful tool that we can use in addition to our BBM ventilations to really help multiply the effectiveness of our ventilations. And so this is a PEEP valve. It goes on the end of a BBM. As you see here, here is the. I'm gonna switch over to the video here. All right. Sorry, guys. I'm going to try this again. So real quick, guys, I'm sorry that there isn't any sound with this. What they're showing here is this is ventilation without any sort of PEEP on it. And as you can see, the lungs pretty much collapse. So remember, the lungs naturally want to just like collapse. That's what allows us to exhale pretty much. So here's what happens when you add some PEEP onto it. So here they've added a PEEP valve onto the exhalation port, and it retains some air into the lungs. And this is super helpful because what this allows us to do is put a little bit of extra oxygen or force some of that oxygen from the lungs into the bloodstream. And it also keeps the alveoli open. The alveoli really aren't useful unless they're open, and we're able to, and when they're open, then we're actually able to do gas exchange with them. Okay. So there's a good article in GEMS if anybody wants to look it up. But this was an agency out in Texas that started to do a bundle of care, and what they did was lower tidal volumes to reduce lung injury when they are ventilating the patient. So not only does that reduce the amount of trauma to the lungs, but also helps reduce that hyperventilation we talked about. PEEP for oxygenation. The other thing PEEP does is, like I said, keeps the alveoli open. One unfortunate downside of ventilating a patient with a BBM is you can open the alveoli and then it can cause them to close again. And that repeated motion is actually pretty traumatic, something called atalic trauma. And that can cause the alveoli to eventually become so damaged that it won't open up whatsoever. Other things we can do, elevate the head of the bed 30 degrees, as long as there isn't any like sort of trauma in these patients. You're good to elevate the head 30 degrees. And then early titration of oxygen. I was taught early at the YSU School of Paramedicine to just go ahead and give oxygen. And since then, that has changed. So the earlier we can titrate oxygen, the better. So one thing I just learned is that there's been discussion up in your guys' area to start using pediatric BVMs for ventilations, and you're implementing that on January 1st. So yeah, that's something really cool. It's good to help keep those volumes low, prevent any sort of hyperventilation. So hopefully you guys can see this video. This was some I took, and these are just some pig lungs. And here we are ventilating. Here we are ventilating without any sort of PEEP. So lungs blow up and then they are deflate really quickly. And so then here we add PEEP. So what happened here is we added a PEEP valve, and this helps reduce the amount. This helps keep the pressure increased inside the lungs. And so too much PEEP, as you can see, could lead to hyperinflation of the lungs and cause damage. It has a good possibility to compress the heart and the blood vessels in the chest. So just something to keep in mind. Our agency does 5 a PEEP on everybody at least, and then we can titrate up if we need to. If you're doing 5, even 10 or 15, or even 10 of PEEP, you have a pretty low risk of causing any sort of compression of the great vessels or of the heart that could lead to some kind of cardiopulmonary failure. All right, so we talked about hyperventilation and some stuff with that. I also want to talk briefly about apneic oxygenation, another tool in the toolbox for our airway patients that's fantastic. It can be done by anybody that can apply a nasal cannula. And what we do is when we make the decision that we're going to do any sort of airway procedure, we put a nasal cannula on the patient. We turn it up to 15 liters a minute. Yes, 15 liters a minute. And that remains on the patient for the duration of the airway procedure. What we're trying to do is give the patient as absolute much oxygen as is absolutely possible. And then we want the lungs to just be completely full of oxygen so that one day when we have to, or later when we have to stop their respiratory drive or sedate them, they still have plenty of oxygen in reserve in their lungs for to be taken around by the blood to the cells, so they don't ever get hypoxic. And so this is a way that we can do that. And the research behind it is actually pretty impressive. So this was what they call a meta-analysis. So 6 different studies, and they looked at 1,000 patients, and the lowest peri-intubation SpO2 for apneic oxygenation. What was it? It was something like, oh, here, they basically the SpO2 dropped on average like 2.12%. So if we can get the patient's oxygen up, put apneic oxygenation on them, it's pretty much guaranteed that you're going to keep it up during the procedure. So, and this is, if anybody follows Jeff Jarvis online, he's fantastic. He did this at his agency. Looked at a before and after group. The before group was 104 patients and the after group was 87. The before group, they just did their normal thing, and then their after group, they made sure to look and do apneic oxygenation with this. And so the amount of the incidence of peri-intubation hypoxia dropped significantly between their before group and after group once they implemented apneic oxygenation. So that was pretty impressive. That's something we really emphasize at our agency, and it's something that can easily be accomplished even in the pre-hospital setting. As I mentioned, I do quality improvement for my agency. So a quick talk about Dash 1A. This is something that came out of the University of Cincinnati's Air Care program. Dash 1A stands for definitive airway sans hypoxia on the first attempt. What that means is that the expectation is, like I said, no longer that we get a tube on the first try. The important thing is that we get some sort of a definitive airway in there. We prevent any sort of hypoxia, and we do all that on the first attempt. That's what they look for. That's kind of the main metric they go after. And it's proven pretty successful for them. So just kind of something to keep in mind that all kinds of agencies are going after this, and it's really helpful and it works well. Okay. So we're going to talk real quick. We can go through, talk a little bit about some of the other core airway skills. So direct laryngoscopy, 5 keys to successfully doing direct laryngoscopy. You got to position your patient, get a good tube shape, have a good technique when you're doing the DL. So thumb up, wing in, and I'll show you what that looks like. So a term called progressive laryngoscopy, which I think is really important and may be a little bit different to some people for the way you perform an intubation, and then passing the tube and following through. So positioning, I think we talked a bunch about this. This is a good position of ramping the patient, where they stick just a ton of blankets and pillows and whatever else they can find to lift that patient up. The aim is to align the ear and the sternal notch, and that's what these 2 white lines represent. Is we've kind of aligned that ear and sternal notch, and that'll allow us the best direct view of those vocal cords when we go in with the airway. This is a physician who I wouldn't be too concerned about trying to get his airway, because he looks like a pretty fit guy. But some patients that have a larger habitus, you may need to really employ a lot of different whatever you can find to try and ramp them up and get them into a good position to ventilate them. Also keep in mind, ventilate, positioning yourself. The airway seat in most ambulances is a terrible place to try and intubate a patient. As a matter of fact, my medical director did a research study on this and found that patients, even experienced medics trying to intubate from the airway seat, do not have a good success rate. So position yourself. Maybe that means doing it outside the truck or somewhere else, whatever you have to do. The next thing for direct laryngoscopy, of course, is tube shape. We want that kind of hockey stick, because as you see here, the laryngoscope blade goes in, lifts things out of the way, and we have that direct line of sight to see the cords and pass the tube. And now we need the tube to follow the geometry that we've created. The next thing is the thumb up, wing in. So like you're toasting champagne, that's kind of the best method to use your laryngoscope to lift up all those structures out of the way and insert your blade. And this leads right into this idea of progressive laryngoscopy. So many times, I think medics are taught that when you insert the laryngoscope blade, you bury it as deep as you possibly can. Then when you kind of lift up, and eventually the airway will fall out, or will fall right before you. And I think that's kind of an antiquated idea. And the reason I bring that up, and this is so the alternate idea to that is this, where we're slowly inserting the blade, and we're taking a look and identifying all the different anatomical structures as we insert that blade until we visualize the cords here, as you see in the bottom right. One reason I think that's especially important is here's a good example of how, if you're not careful, using the former technique I talked about, you could confuse the epiglottis for the glottic opening, or the esophagus for the glottic opening. And so that's something you have to be really mindful, is that sometimes vocal cords can appear but not actually be vocal cords, and that can lead to a bad outcome from our patients. All right, the last thing we talk about is passing the tube and follow through, and why do I have a crazy kid doing the lawnmower? The basic idea is we have that stylet, or maybe you have the bougie in the airway. Be gentle pulling that out. You've worked hard to get that tube established. You don't. Sometimes adrenaline gets the best of us. We don't want to rip that stylet out and pull the tube with it. Anchor that tube as best as we can, and we want to anchor that to the maxilla, the upper part of the teeth. The mandible moves around too much. You could risk losing your tube, so they recommend anchoring it to the maxilla. I'm not going to talk a whole lot about video laryngoscopy simply because there's so many different devices out there. My agency just went from the King Vision to the GlideScope Go, and we have learned that the transition from one device to the other has awoken us to all kinds of challenges we didn't know were out there. If you ever have any, I'll put my info up, and if you ever have any questions about any of these devices and you think I might be able to help, please let me know. But otherwise, I'm probably going to stay away from it for this time. Want to touch on bougie innovation. There is some good research out there that shows that the bougie is better for first pass success, and I would agree with that. The bougie is primarily intended for use with direct laryngoscopy. As I said, we went to the GlideScope Go device, which does have a blade that mimics a traditional Macintosh blade. So we can use a bougie with that. But their other blades they have available for that device are not really copacetic with a bougie. So just keep that in mind, that if you're going to use a bougie, we probably should be thinking direct laryngoscopy. But if we are thinking direct laryngoscopy, we should definitely be thinking about bougie to try and increase your chances of first pass success. So the Vanderbilt way includes positioning your patient, prepping your patient, passing the bougie, passing the tube, and then follow through again. So a lot of the same stuff from the direct laryngoscopy list. As we see, position our patient, prepping your bougie. One cool thing that they do here is they put the bougie into the tube and preload it on there, and then they kind of fold it over. And so they're holding it in one hand. A big complaint I got when I first started teaching Airway with the bougie was that it's hard to manage the bougie because it's a long device and it kind of flops all over the place. And so it's hard to manage it. When you fold it over and hold it with that first hand, that makes it so much more manageable. All of this, of course, takes a lot of practice. So get familiar with it before you go after with a real bougie or with a real patient. As you pass the tube, you can let go and then kind of do a quarter turn to the left. And the reason we do that quarter turn to the left is one pitfall of the bougie is that it can create this gap that we see here. And that's a prime space to get caught on the right arytenoid cartilage or a right side vocal cord. So doing that quarter turn realigns where that bevel is and allows you to pass the tube more easily. And then, of course, follow through, but not like the crazy kid here doing the lawnmower. So. All right. Real quick, talking about surgical airways. If you want to look up an interesting study, this is a study about this app called the Airway app. And basically, they asked people if they performed some sort of surgical airway, to record it on this app anonymously and talk about like the success and stuff like that. And what they found was the typical technique of scalpel bougie, the cricothyrotomy versus an open cricothyrotomy, which includes additional tools versus other types of cricothyrotomy. The scalpel bougie technique is probably the most effective. So we'll talk about what that is. Vanderbilt calls it the slow-mo technique. First thing you do, identify your membrane. You do a vertical or a north-south incision, and then you do a horizontal or an east-west incision. Dilate it out, put the cannula in, you're good to go. We're aiming for the cricothyroid ligament and the cricothyroid membrane right here. So your thyroid cartilage is the big one at the top. Your cricoid cartilage is the one in the back, one right below it, and we're aiming for that space between it. What makes it really nice is if we can puncture a hole into there, we're pretty safe, especially when we're using a scalpel. If we can get in there, we're pretty safe because we're well surrounded on the lateral aspect, and then also posteriorly, the thyroid and the cricoid cricoid and thyroid cartilages are the only ones that are circumferential around the airway. So a question I've been asked before is, if I puncture a hole into the airway, what's the chances I'm going to pass that blade through the back of the airway? And the answer is you'd have to really, really, really try. So just doing it with good intentions, you shouldn't be hurting anybody. And so that's kind of the nice part about putting into the cricothyroid membrane. Identifying the membrane, the first thing you want to do, what they call the laryngeal handshake, where you're using your fingers to really identify the membranes, figure out where everything is, and identify your anatomy. We talked, the first thing you want to do is that vertical incision, and then a lateral incision, and then you dilate it with a bougie, and you stick that bougie in there, and then slide your whoops, going backwards, sorry guys, and then you stick your tube in there. Okay. Once the balloon passes, you're good. You don't need to pass it any further, any deeper. You are well into the space. You don't want to go too deep because then you run the risk of putting it into the right side of the airway. But too shallow, of course, and you could not be ventilating the patient. So, all right, I'm going to talk real quick about supraglottic airways. Like I said earlier, these are things that if your patient's in cardiac arrest and you're an EMT and you want to get an airway really quick and you have an eye gel available to you, drop it in there. You're well within your scope to do that. I also, I'm sorry guys, I don't have I thought I had a diagram of what an eye gel looks like in there, but there are plenty of videos out on the internet if you want to do some research of your own. I want to talk real quick about the role of the assistant during airway management. I think it's a role that is highly underrated. So with these airway cases, it always takes extra hands, and it's even better when those extra hands have clear roles of what they're supposed to do. Remember that there is plenty of opportunities to help out that any provider can do, such as suctioning, assisting with BBM, assisting with apneic oxygenation. I won't get into manual laryngoscopy, but then there's the grab where somebody is taking the side of their mouth and pulling it off to the side. You can actually increase the amount of visibility inside the airway by doing that pretty significantly. And then I put secondary plans because it's really important that we have a plan A, B, and C, and that you have somebody in the background who's getting ready for those secondary plans should plan A or B or C not work. So we talked about apneic oxygenation. So, and always ask the question, are you prepared for failure? Do you have help readily available? Are you headed towards help? Do you have a backup plan? And what should you do with that? What do you guys think? Give me some feedback. Do you want me to go into some RSI pharmacology really quick?
Zach, real quick, there was a question in the chat I'm going to read to you. Does PEEP decrease cardiac output when used during CPR?
In theory it would, but I would say it wouldn't decrease it so, because it's kind of, you got to kind of find a balance. You want to open up the airways, especially when you're doing compressions where you're essentially actively crunching down on the lungs. But at the same, so, anywhere between 5 and 10, you're probably pretty safe. You're not going to decrease it so bad that it's going to really hinder your cardiac output.
Ed, or you had your hand up. Did you have a question? No? Okay.
Okay.
Brian Leapy, you have your hand up?
Yeah, can you hear me?
Yeah.
Mm-hmm.
All right. It seems like going back to CPAP, it seems like every time that we bring a patient into the hospital, whether or not it's respiratory failure or respiratory distress, we decide to maintain that airway with CPAP, they immediately rip it off and throw on BiPAP. I mean, it's pretty extensive the way the respiratory therapists look at it.
Yeah, and that's not uncommon. Respiratory therapists, we have the luxury of using BiPAP. If we could put BiPAP on the trucks, I think that would be the first thing to do. Given the austere nature of how we perform medicine, BiPAP is a little more difficult. The difference really between BiPAP and CPAP isn't much. It's just a little extra pressure as the patient breathes in. CPAP does a great job of improving the patient's overall status, and then BiPAP takes that to that next level. So my apologies if any of my respiratory colleagues have ever offended you by doing that.
No, that's okay.
Without a proper explanation, at least, but that's typically the next step is, we figure out kind of how much CPAP you guys have them on in the field, and then we kind of judge our BiPAP settings based on that. So it's just kind of the next logical thing that we do, the next progression to. They'll stay on BiPAP for several hours before we reassess to decide if we want to take them off and let them breathe on their own for a little while. So,
all right, thank you.
Yeah, no problem. Just as long as they don't rip off the CPAP and don't put anything on to replace it, then there would be an issue. So,
Hey, Brian, I'm curious, what agency are you joining us from tonight?
EMT at Warren.
Okay, cool, thanks.
Yep.
Glenn, I know there's a lot of places, as far as like with regional, locally here, we allow agencies to pick what kind of supraglottic airway they have. So whether they want to do a King airway, which seems to be very common, a lot of people are trying to do research to figure out, should they go to an iGel? With your experience, can you talk on the differences between the King airway and the iGel for some of these places who are looking to switch?
Sure. One thing, my agency is very lucky in that we do a lot of buying, so we have a lot of buying power. So cost has never come into play. I can see where some small agencies may look and see that a King tube may be a lot cheaper than an iGel. An iGel is a little bit more expensive. So if it ultimately comes down to cost, then it may have to be something like that. Me personally, I'm a huge fan of the iGel. I just think it seats better. I think it allows us some additional flexibility. I think that it sizes well to our patients, to what they recommend, and I think it's less steps. It's insert, ventilate, check, confirm with untitled CO2, and you're done, versus insert, blow up the cuffs, and try and ventilate and try and see that after that. So that's why I'm not a huge fan of the King tube. Another thing, there is a little bit of research out there that shows that with the King airway, that big cuff in the oropharynx, especially during cardiac arrest, can occlude the blood vessels going to the brain. So while we're trying to perfuse the head as much as possible and keep the brain cells alive, sometimes using a King airway can be counterproductive to that. So that was another reason we went to it. The other reason we made the switch was, at the time, Kings did not have pediatric sizes, and so we didn't have anything we didn't have any sort of blind insertion device for pediatrics. So that's why we made a jump over to iGel. Since then, there are King airway in pediatric sizes now, but just kind of something to think about. Like I said, I like the iGel. The anesthesia world uses them like crazy. And I mean, anesthesiologists are picky. So I think that's another kind of endorsement of its effectiveness.
Something to consider are innovating LMAs as well. That LMA will go into the airway, and then it'll allow you to go ahead and just pass a tube too, if you need to do that. So those are a little bit more expensive, but those are options out there for some providers.
I mean, every agency is different, and like I said, we have this wonderful thing. We have this wonderful buying power because we buy so much volume, and so that kind of helps us focus a lot more on like what's clinically best for our patients. But if you have to use something else because the budget says so, well, that make the best of what you got. So,
all right. Another question in the chat says, what are some recommendations for improving endotracheal tube success on difficult airways? Like we previously taught bimanual laryngoscopy, things like that. So I'll let you go ahead and answer that.
So I think the tide is changing as far as ET. What is endotracheal? What is airway management success? And that's kind of why I brought up the -1A metric that they're using in Cincinnati. It's not necessarily that you pass an ET tube. It's more that you recognize, okay, this patient is a good candidate for an ET tube. They don't look like they have any sort of external like external factors that may show that they're a difficult airway. If you think about like your lemons and moans, those are some mnemonics out there that are some external factors that can tell you that you may have a difficult airway. So in my mind, it's not necessarily about getting the endotracheal tube. It's about establishing some sort of a definitive airway, whether it be an endotracheal tube, whether it be a King airway, whether it be an iGel, and doing all that while we're monitoring end-tidal CO2, while we're monitoring SpO2, to make sure we're not causing any sort of adverse reactions. Big ones, like we said, are hypoxia and hypotension. So if we're staying away from those guys, and then we establish some sort of a definitive airway, then we've done our job.
And again, one of the things too is, as Glenn says, we're moving away from the intubation role. It used to be go ahead and get that tube right away, or get the tube, and you weren't really a quote unquote good paramedic if you walked into the ER without a tube. Those days are now long gone. And I was doing some research here, and I just want to share some stats with you. The first time success rate for passing an ET tube for a paramedic is 46% to 77%. First time pass rate for is pushing that tube through. For emergency medicine docs, 71 to 87%. And for in-hospital physicians, such as your RRT, 60 to 97%. So you have to stop and think. If you're in the perfect environment in a hospital with all the tools, lighting, and resource that you have, if you're as low as 71 or 60%, then you got to realize that those paramedics out there in the field aren't expected to make all the tubes. So, that's why things like the iGel and the King Airway have come into play. And I think as you go on, you're going to hear that, especially in the state of Ohio, that the EMS committees are looking to get kind of not take it fully out of the scope of practice, but kind of like defer away from intubation for the paramedic level. And that's already happened since I've been an EMT. I was allowed to intubate. I learned that skill, and I was an EMT in 2006. So, things are changing. But if physicians can't do it with all the tools that they have, then, just keep that in mind that, it's difficult. We're not expected to get everything, but as long as you can get an airway, that's more important than trying to go ahead and try that tube. Because what's going to happen? You're going to try that tube. You're going to want to try to do it again. Then you're going to have your other paramedic try to do it. And then what really suffers is the patients and the circulatory system. So just keep that in mind.
Yeah, I think when I was an EMT, I learned to intubate. Never once held a laryngoscope as an EMT, and I think there's definitely a big problem with skill dilution. We have a lot of especially where I'm at, we have a lot of medics. We have actually a healthy population. So we aren't getting the opportunities to do these high risk skills anymore. So because we don't have the opportunities, we don't have, there are probably even fewer opportunities to do it in like a hospital setting in a more controlled situation. So we're kind of left to do it on skills trainers. The good ones are good, but they're never going to you're never going to fully get the full experience of tubing a patient. So between all those different things, it's really kind of tough. Some agencies across the country have gone to where you have to be officially credentialed as an intubating paramedic in order to do that. I think West Virginia is one of those for their street medics, just to maybe able to jump on and confirm. But
hey, Glenn.
Hey.
So when they enacted our RSI protocols, they did do that. So in order to perform RSI, if you're not at the critical care level, you have to be credentialed by your specific agency. But to perform like a crash airway or an arrest airway in the field, normal medics can do that. But if you're critical care, then you can essentially do whatever you want with airway.
Gotcha. Yeah, so I think that's one skill dilution. I think is a real problem that our industry is facing, is that we were at one time given all these high risk but high benefit skills, and as new technology has come out, as populations have gotten healthier, we've had less and less opportunities to practice it on live patients, and so unfortunately our true skills are suffering from it. So we're seeing it getting taken out of people's scopes of practice. So,
Glenn, is Joe. National Registry, they actually studied this a few years back, and it's exactly what you're saying. They found, and I don't remember the numbers offhand, but I was shocked at the number of paramedics that actually don't ever have an opportunity to intubate in like their 2-year research cycle. And they had a majority, it was a large majority of paramedics that actually never intubate. And again, some of it's due to, while it's the captain on the fire department who's in charge of the scene, who gets the intubation, whatever it would be. But regardless, they had a large, and I wish I had the numbers offhand, but I don't. They had a large number of paramedics they found in this study, paramedics across the country, that actually in a year or 2 years don't intubate at all. So you're absolutely correct, because they found that endotracheal intubation is a skill that you see degradation if it's not repeated on a regular basis. And so I think, it's a huge, a lot of people say, well, they're taking away from us, because, they're being mean or whatever. But a lot of it has to do with they're just not getting the opportunity to do the endotracheal intubation anymore. And that is because of other advanced airways or whatever it would be. But, it is a real problem.
Yeah. My agency has over 140 providers, both EMTs and paramedics. And thus far in 2021, we've done 32 endotracheal intubation attempts. So there's never enough to go around, So it's kind of crazy that those are the kind of the numbers that we have out there.
Dan Bouchane, do you have a question? Your hand's up.
Yes, sir. Actually, it's just an addition to the conversation. We're seeing this in medic schools as well. Sorry, I'm close to our casting device. Where we are required by different levels to get an XYZ amount of tubes, and they're just not presenting themselves. So they're having to give us opportunities on mannequins or on sims because we just don't see it in the field anymore. In fact, my brother is going through right now when it's an issue. He has to get like 6 in 2 months, and he's only seen the opportunity twice. And so he's kind of stuck because the ORs are not allowing us in. I know around here we had a medic student like 2 or 3 years ago in the OR that busted some teeth out and then lied about it, and it put all of us students in a bad light, so they won't allow us in to get our lives anymore. So we're just kind of stuck behind the 8 ball trying to get those skills in while we're going through school.
Yeah, so my hospital in Columbus, we also have a CRNA program as well as a medic school. So at one point they asked me to precept the medic students in an airway OR rotation, and some other things came up. There were some other reasons why I declined it, but the one day I went into shadow, like just to try and find an anesthesiologist who didn't have a CRNA student and was interested in letting a medic student attempt on a case that was actually going to get intubated. was like trying to find a needle in the haystack. It was crazy.
Yeah, Glenn, it's Joe again. That's interesting. So I sit on the board for national accreditation for COIA MSP, and actually I just chaired the committee. We revised the student minimum competency requirements for paramedic education, and these were just released, and so they're out there. And that's a really good point that person brought up in paramedic programs, because we're finding that is that and labor delivery are the two most difficult things to get in a paramedic program. And most programs, we have 758 accredited programs across the country, and most programs cannot get their students into the OR. And like you're saying, Glenn, too, if they get into the OR, you have now respiratory therapists in there, you have residents in there, you have CRNAs in there, you have, the anesthesia residents and so forth. And it's so difficult because they're not doing the intubations either like they used to. They're doing a lot of mass cases or LMAs or whatever it would be. And so we just changed that in the new student minimum competencies. It is no longer required, and it's up to the program. So this is still a program specific requirement. But as far as national accreditation goes, we are no longer requiring live intubations. It could be all mannequin intubations in order to get out of the program. Whereas in the past, we were requiring live patient intubation. So that's it's a good point. Whoever brought that up previously with the students, that it's a problem across the country. Not only is the accessibility is an issue, it's also the number of patients being intubated is an issue. And so again, they've gone to basically mannequin competency checkoffs for a lot of programs. So it is a major problem.
Yeah. And kind of the funny thing is some of the research that's out there says that paramedic students learn best when they're doing it physically in the streets versus when they're doing it in like even in the ORs. So it's like, how do we find that? It seems like simulation is starting to become the middle ground where we can get them a decent amount of experience and control when they get it. But it's still tough. But I have some people have like said, could we ever go to the OR and practice intubations? And it's like, no, you don't want to go to the OR and practice intubations. That's not really the best place for you. We'd rather bring you into the sim lab and do it there and run you through a full scenario, and you'll probably get more out of it than going into a controlled environment with the option to defer the case if something goes wrong,
Yeah, that's absolutely true. And there's actually studies out there too that show that after 6 months, there's no difference whether you had live OR intubation experience or you had just mannequin practice. And you're right. I mean, you remember going to OR, you sat on a stool, nice bright lights, you adjusted your stool, you had somebody handing you the equipment, and then you go out in the field and, for your first intubation, you're like, what the hell? I'm out here like,
yeah.
Puts the tube on the floor and it's got dog hair on it and so forth. It's like such an uncontrolled environment. And you're absolutely correct. I do agree. And matter of fact, we just had a group of people from across the country convene. We did a simulation best practice group. So we're going to be releasing that also through COA. And you're absolutely correct that, simulation done the right way is extremely important. I think a lot of it too is muscle memory more than anything. It's just like a police officer, using a weapon in a situation where, they have 1 second to respond, and they say, soldiers and police officers, it's all muscle memory. I think a lot of that too is with the intubation, and a lot of it's muscle memory. It's like once you've seen a glottic opening, you've seen a glottic opening, where a lot of it is more or less the technique and the procedure. So I agree with you. I think simulation is going to actually show that, it's already shown that it's a pretty effective way to actually teach intubation. And in some cases, actually, like you said, it's better putting them in a real situation where they have to manage the airway. That's the other thing they don't do either is when you go to the OR to intubate, it's usually like, okay, come on over here, Glenn. All right, go ahead. Here's the laryngoscope, go ahead and intubate. And you never manage the airway. You never, and then you get thrown out in the field. You're like, well, wait a minute now. I got to manage the airway, and then I got to figure out when am I going to go ahead and do the laryngoscopy? When am I going to put the tube in? So Yeah, it is interesting. So I do agree with you. I think simulation plays a key role in learning intubation, but it has to be the right simulation. The old Fred the Head, that's doesn't do real well anymore. So,
Right.
Yeah, we're actually at Trumbull prepared to anybody who wants to make the drive to Trumbull to set up the sim lab for everybody on this chat right now. So what we're going to do at the end of the chat is we're going to display Matt Gordon's email in the chat at the very end. Anybody, if you want to make the drive to Trumbull, we'll set up the sim lab and make our high fidelity sim lab a difficult airway all the way down to basic airway. And I know Roman Swerdin's on here. Roman, if you can talk to Mike Kerr from Mercy Health, maybe we can make this a joint hospital effort since YSU goes between both hospitals, and get all of our paramedics in this whole region able to get on those sim labs and make sure that their airway competencies are good. But I do know we have the commitment right now as we are speaking from Trumbull. Anybody who wants to come on the sim lab, we're going to do that for you free of charge. So at the very end of this chat, when the whole lecture is done, we're going to display Matt's email address again. Get signed up. We'll do some sessions, and then that'll help push our RSI initiative too, because then we can get you guys in some Craig time. So I know you guys have been waiting for that. We've been kind of like holding off on that because of the sim lab, and we needed to make sure that medical director and chiefs and agencies are prepared for that. But this is a good time to go ahead and say, you want some airway? We're going to give you some airway. So with that, if anybody doesn't have any more questions, Glenn, if you want to put your stuff in the box in a chat, if anybody wants to get a hold of Glenn or copies of anything, reach out to him directly. And it's been a pleasure having you and reaching out. This whole thing just happened by me reaching out with doing protocol developments. I said, hey, can I get a copy of your protocol to see what you guys are doing down there? And he's like, hey, yeah, sure. By the way, I'm a YSU paramedic. And I'm not here to kind of like pat, or say YSU paramedics, are this or that, but we have some of the largest networks across the country and the world. Our graduates from the YSU paramedic program are practicing in multiple countries and all around the nation. And that's how we're able, with the power of Youngstown State University and Trumbull, to reach out and get these speakers from all across the country and the states to speak for us. Our EMS program is in redevelopment, and we're going to be relaunching that here soon. So, great things are coming around. The alumni are strong, and we're here to help you out. Trumbull, YSU, Glenn, Joe, and more speakers as we get throughout the 10 weeks that we're doing. So on that note, Glenn, type your email in the chat. Everybody take a quick little 5-minute break, and we'll resume with Matt Gordon, who's going to do his portion of the lecture.
Hey, Larry.
Thanks.
If you could raise your hand
guys.
for
Take
attendance,
care.
Thank you.
Hey, Larry, this is Roman.
Yeah, Roman.
I'll talk to Mike tomorrow or Tuesday when I go back to work, and we'll talk to him about setting that up if we can, and I'll get back to you on that.
Okay, sounds good.
All right.
Thank you.
Yeah, Mike's out playing Santa tonight.
Yes, he is. He was Santa all day today.
Larry, this is Rob Tish from Canfield. 3 of our guys are on call, so Joseph, Wilkinson, and Blevins won't be able to raise their hands.
Okay, no problems. If you just want to kind of fill them in what we got, and we're definitely going to be sharing the videos this weekend. We'll send everybody copies of the links to get the videos so they can watch what they missed. But thanks for the heads up.
They literally just all left here in the last 5 minutes, so they've been
okay, no worries
the majority of the time.
Thanks, Rob.
Hey, Larry, quick question. This is Jenna Rendis. Are you there?
Yeah, I'm here. Sorry, my microphone froze. Go ahead.
Okay. Back to the end title when you're CPAPing your patient. I find that my numbers really don't change in the amount of time that I'm transporting on most patients. Is that like normal? What is the time frame that it should be improving?
Glenn, are you still on here? I think Glenn may have
I
stepped
think
away.
he left.
That's okay. So yeah, there's going to be a little bit of delay, and with the CPAP, remember you're forcing the air in. That's not really allowing them to ventilate that back out. So the oxygenation part is improving, whereas the exhalation might not be that great.
So the
But
numbers just aren't going to change in the amount
the
of time
numbers may
they're
not change depending on
transporting.
how well they're actually exchanging that air. Yeah.
Okay.
So the CPAPs to force the air in to make the breathing a little bit easier, but they may still have difficulty getting that air out, and so that might be why you have some delayed in those readings. But it depends too. So what we're finding is if it might be a little bit more accurate if you use the nasal cannula under end tidal underneath the CPAP mask, so we can
Okay.
get a little bit accurate reading versus maybe attached to that CPAP mask in that inline. It really depends how your patient is breathing too. If your patient is mouth breathing, then you absolutely want to try to use that inline connected between your mask and your circuit. If they're not and they're really breathing through their nose, then try that nasal cannula end tidal, and you'll be able to maybe get a little bit more accurate reading.
Okay. Thank you.
You're welcome.
Okay, everybody, we're going to get started back up here in a minute. Give you all a chance to get back to your seats or wherever you're at. Okay, we're going to go ahead and get started. My name is Matt Gordon. I'm the director of EMS for Trumbull Regional Medical Center. I introduced myself at the beginning, but I don't know if I got everybody. I'm a 1993 graduate of Youngstown State University, one of Mistovich's students. I know you'll see a lot of us on here. I've been seeing some YSU here, so I kind of thought maybe, we'd bring sexy back. Oh no. So
that's awesome, Matt. Is that your field internship code? Matt.
Tonight I'm going to be talking to you about caring for at-risk populations. We deal a lot with the at-risk populations, don't we? I mean, a lot of the calls we have are abuse related, or we deal with the elderly constantly. That's a big part of our business. Another thing we're going to be touching on is human trafficking. And we'll be talking about how Ohio is one of the biggest places for human trafficking. We're going to learn how to identify these populations and learn how to communicate with them and recognize potential abuse. I do want to say, however, though, that we can't possibly cover every at-risk population. And it depends, I guess, on your definition of an at-risk population. But there are a lot of different populations that are at risk for different kinds of abuse and things like that. Everything from the LGBTQ community to small communities of racists, of racism with small communities of immigrants and whatnot like that. So we're going to start out with domestic violence. In Ohio, there were 131 domestic violence in the year ending 6/30/21. During that same period, more than 2,600 victims were served by the Ohio Domestic Violence Network. That's a lot of people, and you're going to see them, and these are tough situations to take care of. One of the first things we need to remember about domestic abuse is that domestic abuse can happen to anyone. We typically think of the abused wife or girlfriend or something along those lines. But abuse can happen to husbands and boyfriends. Abuse happens to same-sex partners. Abuse happens to people that just happen to live in the same house together, communal living, things like that. So understand that domestic abuse can happen to anyone, and we need to be aware of that, and we need to be looking for it. Abuse is a repetitive pattern of behaviors used to maintain power and control over an intimate partner. Nowhere in that definition does it say anything about love or respect or anything else. It is a pattern of behavior, and its sole purpose is to maintain power and control over somebody. The National Domestic Violence Abuse Hotline defines abuse as the following: physical, which is of course hitting, slapping, choking, anything along those lines. Sexual domestic violence. It wasn't very long ago that marital rape wasn't even a thing, but we've grown as a society. We don't allow that to happen. So there's lots of sexual domestic violence. Emotional control is one of the biggest tools that someone uses in domestic violence and domestic abuse. Emotional and psychological control over a person is very, very, very powerful. A lot of times we ask the question when we're on an abuse call, or maybe you've been to this same house several times, and you think, man, why doesn't she just leave? Well, the first question, the first answer to that is, well, why doesn't he just stop? Or she just stop? Why doesn't the abuser stop? We always want the abuser to leave because they're conditioned that way. It doesn't take very long to condition somebody this way with these kinds of abuse and these kinds of tactics. There's also economic abuse. And economic abuse is usually used to isolate somebody from their family, their friends, or anybody else who might be able to care for them. If you control the money, you control how much gas is in the car. You can control how they talk, who they talk to, on what phone, and things like that. And that's also another very powerful tool. And I think you'll see some of these themes, maybe not with the exact same definition. You're going to see some of these themes recur throughout the different subjects that we talk about tonight. One of the behaviors of the abused, when you're looking at the victim, how do we pick out this victim as a person who's being domestically violated? Well, a lot of times the victim's going to seem overly afraid or overly anxious to please the partner, even after the partner is the reason you're there. I've literally seen somebody go get their husband a beer while they're holding on to their bloody eye and telling the ambulance, wait, I'll go with you in a second, I have to take care of him. These are very powerful things, and it's hard to break this cycle. A lot of times they're overly compliant or overly obedient, and that's kind of self-explanatory because they're going to do everything they can do. They're going to walk on eggshells to not upset this person because they think it's their fault a lot of times. They check in very often with their partner. A lot of times these partners are very jealous. They're very afraid of getting caught for abusing their partner, and so they make sure that they check in with them all the time. A lot of times, even at work, maybe this person has to, if you don't call me every hour, the abuser is going to show up at work or something along those lines. They tend to have low self-esteem, whether that's before the abuse started or caused by the abuse. That's up for debate, but they tend to have very low self-esteem. And they'll often present as very anxious, depressed, or suicidal. Take all of these things very seriously. It's a package deal. These folks are in a serious crisis. They tend to feel very helpless because the abuser programs them that way, programs them to think that nobody's going to help you, nobody cares. And for whatever reason, the abused tend to believe that. People who are abused oftentimes will minimize or deny the severity of the abuse. It's not that bad, or it only happens when he gets drunk, or it only happens when he's doing drugs or something along those lines. And so, they tend to minimize this or deny that abuse because they're still trying to protect this partner. Rationalization and self-blame goes hand in hand with that. They blame themselves. Well, if I didn't make him mad, he wouldn't do these things. And when you have the chance to step back, that sounds so ridiculous, and it sounds like it would be so easy to break. But unless you're in this person's shoes, it's very hard to understand their thought process. You can't apply your thought process to what's going on with them. And then finally, drug and alcohol abuse. And you'll see that that's also a theme throughout this entire talk. Both the victims and the abuser and the abusee, a lot of times tend to have issues with drug and alcohol abuse. Some of the physical implications of domestic violence. And these are all things that you've probably heard, you've probably seen, even in your daily life, maybe not even in your EMS life. First, people that are frequently injured with excuses of accidents that don't add up. These stories usually don't add up. Frequently missed social engagements, school or work, sometimes with, again, bogus explanations, bogus excuses. You'll find that they dress in clothing that hides injuries. If someone's showing up for work in a turtleneck in the middle of July, they may be doing that to hide choke marks, to hide bruising, to hide some sort of injury. Try to be cognizant of those things. Another thing you'll see throughout this whole thing is multiple stages of healing. Abuse is very rarely a one-time deal. It's very rarely that somebody just snaps one time and this is what happens. Most of the times, this is a process. It's a very deliberate process many times too, to gain that control that we talked about a couple slides ago, to gain that control over another human being. Again, this has nothing to do with love, or anything else. It's a craving to control another human being. To that end, abusers tend to have very poor impulse control, and that makes sense, doesn't it? They tend to fly off the handle and things like that. Drug and or alcohol abuse. They will always blame the victim. It's never going to be their fault. The only time that an abuser will say anything about it being their fault is when they're going through an apology phase and they're saying, "Oh man, I'm sorry, and that will never happen again." And all of those very things that we see on everything TV shows to hit the news to on the calls you're on. It's very frustrating. Unfortunately, the script seems to be very similar in a lot of domestic violence cases. I mean, I'm sure there's plenty that have a lot of unique things to them, but the recipe seems to be kind of the same, and it's frustrating that sometimes we miss that. Often use humiliation, intimidation to gain power. Again, that goes right back to just gaining power over another human being. Gaining power over another human being and imposing your will on another human being. Excessively controlling or jealous. Why are they so controlling and jealous? Well, probably as much as to protect themselves as to protect the power that they've gained over this person. They don't want this person going out and reporting the abuse or being seen with their wounds or anything like that. And so they use these things to keep them isolated, to keep them away from people who might help them or who might help them leave him or her. One of the very difficult things on a domestic violence case is the interview, because often the abuser won't be out of earshot of the person that's been abused, and will jump in and answer for them. And you'll notice a lot of times that when you're interviewing somebody, every question you ask, they look at the abuser to check the answer, to make sure that they're answering this correctly in the abuser's eyes, not correctly in the real eyes. As I said, these are very, very dangerous calls that we go on. My father was a police officer for 30 years, and he said, he always said that the most dangerous thing you can go on is a fight between family members because you never know what's going to happen. Oftentimes, the abuser and the abusee will attack you, verbally or physically. And we have to be aware of that. We have to be able to protect ourselves. We need law enforcement on these scenes. They should already be there, and if they're not there, you should call them. A couple safety tips. One general safety tip that I have that's not on this slide is don't ever stand in front of the door. don't ever stand in front of a window. You stand off to the side of a door when you knock, or you make sure that you're aware of windows around you so that you can avoid them. Not trying to be overly dramatic, but people get shot through doors, people get shot through windows, or injured through windows, things like that. We need to be aware. These folks don't want caught. We have to be aware of where we are, and always be aware of where your partner is. Your head has to be on a swivel. Don't let anybody block your exit. Don't let people get behind you. Don't let people separate you from your partner into a separate room or anything like that. It's very important. If you're to the point that you're that uncomfortable with it, that you think you're in danger, then as much as we hate to do it, we have to leave. We have to protect us and our partner self first, because other than that, we can't help the person who's being injured. So law enforcement is very, very important on these scenes. You need to adjust your questioning as needed. You need to watch what you say around the potential abuser. You don't want to set them off. You don't want to set them off to come after you, or to visit more damage upon the person they're already abusing. So we need to adjust our questioning, not only the kinds of questions we ask, but we want to try and get this person away from their abuser. Physically remove them from their abuser. Best way to do that is sometimes we get them into the back of the ambulance and tell the potential abuser, hey, we don't allow riders. And a lot of times that'll work, and then you can talk to that person in the back of the ambulance without any interference. Speaking of the potential abuser, be real careful. Don't touch them. Don't invade their space, especially if they're aggravated or aggressive. We don't want to be in a fight. We don't need another victim. We don't need more drama. We don't need any of that things. We don't need to get hurt. So be aware, people. You know, if this person's already fired up, and you walk in there and you try to usher them out of the room or push them out of a room or something, you could end up in a fight. The best way to stay out of a fight is to stay out of a fight. You want to maintain eye contact. You want to make sure that the people that your victim knows that you are paying attention to them, that you are focused on them. You also want to make sure that the potential abuser, if they're in the same room and everything, knows that you know where they are. So it's a balance. Like I said, it's a very tense situation. We have to be aware. We need to be aware of the nonverbal clues. Look at the body language, the demeanor. Look at the looks between the abuser and the abusee. Like I said, sometimes the abusee your patient will look to the abuser before they answer questions. Those are all clues that something is going on. So we need to be aware of those. From personal experience, avoid assessing domestic violence patients in the kitchen. Everything in the kitchen is a weapon. Be aware of what's around you. Look around. There might be a shotgun in the corner. There might be something else. Who knows? We need to be aware of what's around us. We need to keep ourselves safe. Again, head on a swivel. Communication is key. You have to be able to communicate with dispatch. You have to be able to communicate with your partner. You need to be able to communicate with law enforcement. This is one of the cases in communications. We've gone to plain English for the most part in most places. Here's the place where you need a code. You need a code word or a code number, so that you're not getting on the radio and saying, hey, get me police here, because the word police might be exactly what sets this off. So you need to have a code or a discrete button, something along those lines, that can help you get the help you need when you need it. Documentation is key in these treatments. These are cases that oftentimes go to jail. Your documentation, or go to trial. Your documentation is going to help drive what kind of help this patient gets for the rest of their stay, for the rest of this entire situation for them. So we want to describe the patient's location, their emotional and physical condition. Look at them. Are they unkempt? Are they malnourished? Any of these things, these are all these are all clues. Every little bit's a clue. It's important to document the injuries very, very thoroughly. Be very descriptive, especially if they have distinctive marks, distinctive hand marks, bite marks, things along that line. We need to document these very, very thoroughly. Document any history of abuse or restraining orders that might be in place. That's also very important. If we document that, John Smith was here and John Smith wasn't supposed to be there, that's going to be a help to the victim. Document statements made at the scene and during their treatment, especially if the suspect makes any admissions. Happens more often than you might think. If you're hearing the conversation off behind you and that's what, he's saying, oh man, I can't believe I did this again, or something along those lines. Boy, is it important that you document that. And yeah, you're probably going to be deposed over that document and stuff. But if your documentation is solid, it's going to carry out. You won't have anything to worry about. Make sure you document the overall surroundings. What's the house look like? Are there holes punched in the walls? Are the windows broken? Is it filthy? Is it, things along that line? Unfortunately, they always seem to be some part of the puzzle, don't they? And if appropriate and if allowed, this doesn't always fall onto EMS, photographs of the injuries, photographs of the surroundings, things like that. Always keep in mind that the patient's privacy and all of the laws that apply to this. But if it's appropriate and if it's okay to do, it's not a bad idea. Follow your department's policies and your protocol, though, on that.
And Matt, can I interject one thing there?
This is sometimes where EMS ends up doing a little bit of police work. It's important that we preserve any evidence. Oh, go ahead, Joe.
Oh, I just want to say one thing. We always teach students to make sure that you are documenting, objective information in the, PCR, and that's important. But, and you can't write in your PCR that, abuse victim. You really can't, say, but what you could do is you found the patient here and the objective signs and symptoms that you see. But one thing that I do want to say is that, once you get done with the call, there is nothing that would keep you from taking a legal pad and writing everything, as much as possible, like, maybe weapons found on the scene or whatever. Describe the scene, describe how the patient was feeling, what the patient was telling you, so forth, and sign it and date it and tuck it away, because that will be allowable for you to actually bring with you in the deposition. So not only will you have your PCR, but the PCR will have limited information that really is, focused on the patient, but you also will be able to bring with you your own personal notes from that day, as long as they're signed, as long as they're dated, and you verify that those are your notes. You will be allowed to use those during a deposition, and obviously if it's used during a deposition, be used during a trial, because a lot of these things are occurring 5 years later or so, and you go back and what these attorneys, their intention is to try to trip you up, because if they trip you up, then they discredit you, and so they ask you the same question about 10 different ways, and they're trying to get you to answer it, opposite of what you did. So therefore, continuing to be able to refer to your PCR and refer to your notes is extremely helpful. Instead of trying to say, you can remember exactly what happened 5 years ago, because they set you up too. Like, well, you work 24-hour shifts, and you're like, yeah. And how many calls you running in a 24-hour shift? Oh, about 10. And so, 10 calls. So 10 times 24 times number of months. Well, you're running the next number of calls a year, aren't you? And then 5 years you ran this, and then you're like, well, yeah, I did. And they make you feel like, oh, well, this is, I'm a really hard worker. And then they tear you down, because they're like, how the hell could you remember this one call out of the last 5,000 calls? So, that documentation is important. So feel free, and you can use it. You can use personal notes that you sign and you date in a deposition.
That's all very true, Joe. I appreciate that. One of our policies at Brookfield Fire Department when I was there was if you had an issue like this, that yes, you would do a patient care report, but you would also do an incident report that we would file away for you just for that specific reason if you were to need it down the road. We started doing that because of a couple of very specific cases at Brookfield, and it actually paid off. So in speaking of going to court, we want to help preserve the evidence if we can. We want to minimize our impact on any scene, on any potential crime scene, not just domestic violence. We should advise law enforcement about our suspicions, about the injuries, and about any statements that we may have heard that either they didn't hear or happened before they got there or whatever. All crime scenes, you want to have personnel use the same entrance. It just minimizes tracking, destroying evidence that might be on the floor, trace evidence, things like that. Preserve clothing. If there are stab wounds, if there's blood stains, if there's bullet holes, try not to cut through them if you don't absolutely have to. They're just useful for court. And if the injury shows evidence of a specific object, advise law enforcement. For example, if you look at someone's back and they have a perfect imprint of a belt buckle that looks just like the belt buckle that the potential abuser is wearing, it's very important that you should point that out to law enforcement and document that as such. What are some of the barriers to EMS reporting domestic violence? A lack of time. We're only with these patients sometimes for a very short period of time, and we seem to run out of time. Well, you need to take extra time in this case in your assessment to discuss violence, and you need to take extra time when you get to the hospital to make sure that the correct people know what your suspicions are and what you think is going on. Because I'll be honest with you, if you have suspicions that strong, you're right. Very rarely are you going to be wrong. I can't tell you how many times in how many different classes and stuff I've told people, trust your gut. If your gut tells you that something is screwed up, odds are it's screwed up. Oftentimes we have a lack of training. So how do we get around that? Well, we get training. We figure out what our local resources are. We talk to the people on the mental health board and the Trumbull County Combined Health District. Participate in these different committees and stuff so that we get the correct training and understand what our resources are. Sometimes we're afraid of offending people. The first time you say, well, ma'am, is somebody hurting you? And they might get very defensive about that. But explain to them that you ask all of your patients about violence. In the ER, there's a list of questions that everybody gets asked. Do you feel safe at home? Do you feel, all those questions? Everybody gets asked them. Every socioeconomic status, every color of person, every gender, doesn't matter. Everybody gets asked those questions. And bias. Nobody wants to talk about bias, but we need to overcome our biases. If we don't, maybe we don't support whatever relationship that these people are in or whatever, but we still have to protect that sanctity of life of that patient, no matter what we feel about their lifestyle or anything else. Biases are real, prejudices are real, and we need to get over them and let that and take care of the human being. That brings us to child abuse and neglect. Folks, these are some of the hardest calls you'll ever be on. They can be very emotionally draining. They can be very hard on the provider, and they're obviously hard on the child and all the people around them. In Ohio, in 2016, which was the last time I could find any stats for some reason, almost 30,000 cases of physical neglect were reported, or physical violence against children was reported. Over 25,000 cases of neglect against children were reported. Over 9,000 sexual reports of sexual abuse. Now, these are reported. Can you imagine what's really going on? What the numbers must really be? And unfortunately, of those 1,750 children died in 2016 as a result of abuse or neglect in the state of Ohio. That's just in the state of Ohio. So you are going to come across these calls. We should always suspect abuse when there's discrepancies between the history and the degree of injury. This happens all the time. No doubt. This happens all the time. You know, even when you read in the paper about child abuse, you know, the excuse was, well, my kid fell out of bed. Well, first of all, your 8-month-old child fell out of bed and broke 6 ribs. That doesn't happen. That doesn't happen unless there's some, you know, osteogenesis imperfecta or something along those lines. There's changes in the story, sometimes rapid changes in the stories. It's very hard to keep track of lies. I can't remember who said it, but there's a famous quote out there that says, if you tell the truth, you don't have to have a good memory. When you're lying, you have to juggle the lies, and oftentimes you'll see the changes in the story. Inappropriate responses from the family, you know, indifferent to the child's injury, or, you know, the rest of the family. You know, you come into a house and there's a child in the back bedroom who's emaciated and has been back there and living in filth. The 3 other siblings aren't living that way, and they're sitting there playing a video game because this is normal to them. That's how this child is always treated, and it's become normal to them, and that's very sad. Prolonged interval between the injury and the call for help. You know, when a kid has a broken arm or something along those lines, and by the time they call for help, the bruising's already yellow, or the arm's already started to set itself or something along those lines, or they don't even call for that injury, but then injuries pile up. And a lot of times that's what happens is injuries pile up on this kid, and then they eventually have to get some help. The history of this injury is inconsistent with the developmental level of the child. Yeah, your 8-month-old kid didn't fall off a ladder. Your 8-month-old kid, you know what I mean? Take a look at what the developmental level of the child is, and these stories aren't going to match up. And here's that multiple stages of healing again. You know, when we see bruises and cuts and burns and things like that are, you know, this bruise looks brand new, fresh, and that bruise is yellow, and that bruise is purple, and this bruise is fading. It's a consistent system of abuse to gain power over another person. That's all it is. There's no romance to that. That's what it is. It's a systemic abuse. I see I have a couple hands up. Christina, do you have a question? Oh. No? Are there any other questions? I saw a couple hands up. Okay, we'll move on then. So this multiple stages of healing, you're going to see that. You're going to see that. You need to look for it. If the bruises don't look right, it's because they're not right. You have the skills, you have the training to figure this out. Risk factors for child abuse. Age. The CDC reports that children under 4 are at the greatest risk for severe injury or death. Our most vulnerable of children are at the greatest risk, and that's really unfortunate. That also coincides with a few other things, such as low income, race, and ethnicity. This actually comes into play. The statistics actually show that Caucasian and white have a much higher abuse rate than other races. And it's, you know, that's just the way it is. It's just science. It's the statistics. Temperament. You know, do they have a difficult temperament? You know, if a parent is already stressed, a parent is already debilitated and everything else, and then they have a child that's tough to deal with, that can be that straw that breaks the camel's back. That's not an excuse for abuse. That's a reason. Physical, cognitive, or behavioral disability. Again, these are our most vulnerable children. These are our most vulnerable children, and they are absolutely at the greatest risk for severe injury. These kids need help. They probably have some of these disabilities because of abuse. That's that vicious cycle. My behavior's bad. They abuse me. That makes my behavior worse. They abuse me worse. That makes my behavior worse. They abuse me worse, and that's how that works. Chronic and serious illness. Again, these are our most vulnerable. They're our most vulnerable. They're the easiest victims for people who have this propensity to abuse children. And childhood trauma. You know, kids that have been through, some kids have been through things that kids should never have gone through. And that actually makes them more susceptible for child abuse as they age. What are some of the risks that we might see, that we might be able to define between the parents and the families? What are some of these risk factors? There's that substance abuse again. Are they abusing substances to medicate themselves because of their mental illness that causes them, that is a factor in them abusing? Or is it the other way around? Who knows? To me, I bet it's a vicious cycle, just like with the abuse. Parental immaturity, impulsivity, and low self-esteem. I'm going to add into there parents with learning disabilities come into this category also. You know, I'm not even just talking about kids having kids, because there's 20-year-olds out there that are perfectly capable of raising their children, don't abuse anybody, don't, you know what I mean, don't do any of these things and do a wonderful job. But that immaturity, sometimes when those kids are so young and they don't have a family support with them, they reach out, their brain's not even developed and they already have children. They act out, and this can happen. Add to that the stress of caring for a child and unmet emotional needs, especially if they're already an immature or young parent. That stress can be overwhelming for some people. Some people cannot take that stress. Again, this is not an excuse for abuse. It's just a reason. Lack of social support, sudden economic crisis. You know, when the stress piles up on people, and then you have a kid that has special needs, or you know, is difficult, or whatever you want to say, and all these things all these stresses start to pile up on them. Some people aren't mature enough or have so much impulse or such low self-esteem that is exactly how they act out. A home where there's domestic violence. Domestic violence begets child abuse very easily. Obviously, the recipe's already in the home, the poison's already in the home, and that's where we end up. You know, we graduate from domestic violence to child abuse, or vice versa. Lack of parenting knowledge or skills, lack of communication skills. You know, a lot of times these kids were raised without, or the parents of these children were raised without any support, without anything, without any emotional help, without any training, without any, you know what I mean? They just don't have, they were never given these knowledge or skills, and they have a lack of communication there. Lack of communication and lack of skills adds up to a tragic outcome. A lot of times parents have unrealistic expectations of their children, or inaccurate knowledge about child development. Can come into play with potty training. Potty training can be a set off for child abuse. Some people believe that you can train your child to use the potty by spanking or beating their butts or whatever you're doing. But you know that it's inaccurate knowledge. You have unrealistic expectations. This can also go up into, you know, our older kids, where parents have expectations of straight A's and B's, or you being that starting basketball player or something, and it's unrealistic for this child, and that can lead to abuse. Very, very often, the parents or the caregivers suffer from depression, anxiety, mental illness, behavioral issues, things like that are just that they're actually mad at their children or abusing their children over the same things that they have, and that's that sad, vicious cycle. I don't know the answer to break it, but boy, it needs broke. We seem to deal with the same family units over and over and over. Parents often have a feeling of insecurity and a lack of trust, and again, that probably comes from a lifetime of domestic abuse, violence against them when they were a child, substance abuse. All of these things add up to that, to the feelings of insecurity and a lack of trust. They don't trust anybody. But then again, they can't trust anybody because they're doing a terrible thing and they're going to get caught. What are some of the things in the community that put these kids at risk? Well, socioeconomic status, and that's an easy one. Social isolation or lack of support. A lot of kids either don't have friends or aren't allowed to have friends, or are latchkey kids and come home from school and are in the house until their parents get home from work. Maybe their parents work afternoon turn. Then by the time they get home, bad things might happen. Kids who tend to live in a dangerous or violent neighborhood. We absorb what's around us. We absorb this community violence. If the violence is acceptable in our community, if that's what you live with every day, if the answer to your conflicts is to strike people, and that's what you're seeing every day, and that's what's normal in your neighborhood and in your community, that's what you're going to do. Hand in hand with poverty. Which leads to a lack of access to medical care, health insurance, adequate child care, social services. A lot of times we say, well, all these things are available to you. They're all available to you, but you're using rational thought, whereas the person who is in charge of this child isn't using the same kind of rational thought that you are. They've been through all of these things. They've experienced everything that we just talked about. And here's the end result. Some of the societal risk factors are, of course, homelessness, racism and discrimination, poor schools, exposure to environmental toxins. For a while there, lead was in the news big time in Detroit. The dirty part of that whole deal with the lead exposure to those kids in Detroit is these kids were already in poor schools, some already homeless, already experiencing racism, already experiencing all of these things, and then we're slowly poisoning your brain to death with lead. That leads to impulse, hard impulse control, learning disabilities. All of these things crank up the pressure on these families, and again, not an excuse, but it's a reason. Some places have a very narrow legal definition of child maltreatment. I can tell you that it's very frustrating when you do report something and social services or children's services or whatever comes and investigates and leaves the child in the home. They have certain parameters they have to meet. Sometimes they have a very tight legal definition. And the social acceptance of violence, as we discussed just a minute ago. Emotional abuse of children is a pattern of behavior that impairs a child's emotional development and a sense of self-worth. It's very difficult to prove, but it's always present in conjunction with other types of abuse, with the physical abuse, with the social abuse, with all the other abuses. Some of the indicators of that are conduct disorders such as being antisocial, excessive fighting, being destructive, destroying their toys for no reason. Habit disorders such as rocking, biting their nails, pulling out their hair, pulling out their eyebrows and eyelashes is one for girls especially. Lags in physical development and failure to thrive. That's because they're suffering probably several different kinds of abuse, and we want to be able to step in. These kids are going to present with a lot of anxiety, sometimes speech disorders, sleep problems, all these things that kids should not have to be worrying about. These kids have to worry about. Sometimes they're excessively withdrawn, fearful, or overly anxious about making a mistake. A kid might, spill milk and just be losing their mind because, oh my God, I'm in such trouble. That should really raise a red flag. Extremes in behavior. Sometimes extremely obedient, sometimes extremely disobedient. They have extremes in behavior. They're looking for their way. A lack of attachment to the caregiver. Sometimes that's very obvious. Sometimes it's very obvious when the caregiver is in the room and they are just totally indifferent to it. Acts inappropriately adult, taking care of the other children and stuff like that. Like if you see a kid that's 9 years old and they're taking and they're giving the kids a bath and changing the diapers and making dinner and stuff like that, that's inappropriate. It's awesome of them because they must be great people to do it, but we got here by devious means. Or inappropriately infantile, showing that total lack of maturity. What's physical abuse? It's a non-accidental physical injury inflicted by the parent, caregiver, or other person who has responsibility for the kid. What are some of the indicators? Same as we see on a lot of other stuff. Injuries are unexplained bruises, welts, cuts, burns, especially location of these injuries. If a kid's got a burn in the middle of their back, they didn't put it there. It's not an accident. Fractures of the face, especially bilaterally. The excuse might be, oh, he ran into a doorknob. Well, yeah, how'd that blacken both eyes? Unusual injuries. One of the big ones is scapula fractures in kids. A, it's very hard to fracture your scapula. B, how'd that happen? And a lot of times it's from a severe slap or punch to the back. Swollen and tender limbs. Look up at their upper arms and you see a handprint. Injuries that appear to have a pattern, such as marks from a hand, belt, or cigarette, or cluster bruising, where it's apparent that somebody threw 5 or 6 punches, into the side of their head, and there's 5 or 6 distinct clusters of bruises. These children tend to be overvigilant or alert, as if waiting for something bad to happen, because you know why? They're waiting for something bad to happen. That's why. They shy away from touch, flinch at sudden movements, and a lot of times don't want to go home. They'll make every excuse to not go home, to hang out at your house or to stay at school. Inappropriate clothing to hide injuries. We've touched on that before. That's a very real thing. If this kid's coming to school in a hoodie in spring and it's 80 degrees outside, maybe we should take a look. Huge indicator for kids right here, sudden changes in behavior or school performance. Teachers are critical in noticing that, and they do. I think they do a wonderful job. I'll bet they help a lot of kids. Not receiving help for problems that were already brought to the parents' attention. I can't help but think of that young man who shot some people not too long ago in the school, and his parents were, from what it seems in the media, his parents were given the tools or given the information that they needed to step in and literally chose not to. I wonder how that's all going to play out. Learning problems that can't be attributed to other causes. This kid doesn't have attention deficit disorder or anything else, but has learning issues. It could be a sign of abuse. Overly compliant, passive or withdrawn, sometimes even emotionless. Suicide attempts or threats. If children attempt suicide or threaten suicide, there's a problem. Yes, mental illness is one of those problems, but we need to look at the total package. A child who attempts suicide is the ultimate cry for help. We're obligated to help them. Lack of attachment to the parent, destructive, aggressive, and disruptive behaviors. The caregiver behavior and physical abuse, they show little concern, oftentimes deny the existence of the problem or blames the child. Multiple attempts to conceal the injuries. They'll use multiple hospitals or doctors. The explanation of the injuries just don't add up. The history conflicts. Discipline does not fit the infraction or is inappropriate for the child's age. If you're giving a full man swing to the butt of a 1-year-old, that's not appropriate. History of abuse as a child. We got to break that chain. We got to figure out how to break that chain, man. Rejects or is indifferent to the child. Poor impulse control and drug and alcohol abuse. These are all the same things we see quite a bit. I'm gonna try to blow through this, even though it's hugely important. I'm sorry if I'm running a hair over. Sexual abuse, fondling a child's genitals. It's never ever okay. There's no excuse. There's no excuse. Of course, penetration, incest, rape. When I read the paper and I see that a child, child sex crimes or anything like that, anytime there's sex with a child, it's rape. Sodomy, indecent exposure, exploitation through prostitution or production of pornography. Unfortunately, we've seen this in the newspaper quite a bit lately, where we see these stings and we see these people that are arrested for and have these huge caches of child pornography, and we see these stings where people are going to meet underage children for sex, and thank God it's a cop that's catching them. Exposing a child to pornography or sexual situations is a big deal. That's a grooming tool. That's a big grooming tool to normalize that for children so that you can move them on to the next level. What are some of the physical indications of sexual abuse? Trouble walking or sitting. Excuse me. If a child has an STD, there's a problem. Pregnancy, especially under 14 years. Now, some kids experiment in sex and end up having a baby or what, you know what I mean? Yes, that does happen. We're not talking about those folks. We're talking about these young kids, 14 years old and under. Pain, itching, bruising, or bleeding in the genital area. If they have bruising or bleeding in the genital area as a child, or pain, it's not normal. We need to investigate that. Torn, stained, or bloody clothing. If it looks like their pants were ripped off or their shirt was ripped off, or stains or blood in certain areas of their anatomy on their clothes, that is a huge indicator. Some of the behaviors for children who have been sexually abused, they have a knowledge or an interest in sexual acts or seductive behavior that is inappropriate for their age. Sometimes this is really apparent. It's really apparent to you. What a red flag when a child knows terminology and knows certain things about sex at a young age. Not normal, folks. They make efforts to avoid a particular person without an obvious reason. They don't go near Uncle Charlie. Does not want to change clothes in front of others or participate in physical activities. Very often runaways. There's a case going on down right now in Athens, Ohio, that I've been following. That's a family that seems to have like a cult type relationship. And this girl ran away, and they were supposedly looking for her, but she was hiding. She came out of hiding and exposed the entire thing, and I've been kind of following that down there. I know we have some people from down that area on this class. That's a very sensational case. Not sensational good, sensational in like, what the heck. Displays poor peer relationships. Can't seem to make friends, keep friends, things like that. and exaggerated fear of close physical contact. You know, a kid that gets a normal hug from a person who would be appropriate to hugging them, hello or goodbye, and then just totally recoils. The caregivers tend to be overly protective or jealous of the child. They encourage or force prostitution on the child, encourage or force sexual acts in their presence. They abuse alcohol and drugs, and oftentimes force alcohol and drugs on a child. Tend to be geographically isolated or lack social and emotional contacts outside the family. That seemed to really be the case with that family down towards Athens. And of course, low self-esteem, because that just makes, that's that chain. They were probably victims, and now they're going to victimize themselves. Child neglect. This form of abuse can be very difficult to identify. It's just you neglect to give the child food, clothing, hygiene, shelter, or physical supervision. These kids tend to be consistently hungry, obviously malnourished, oftentimes poor hygiene. They lack sufficient clothing or are inappropriately dressed for the age or season. They're taking whatever clothes they can find and going to school. Unattended medical problems, medical or dental needs, immunizations, or glasses. You know, the teacher has told them, hey, your kid can't see, and they don't take him to the eye doctor. Hey, your kid has bad breath and looks like he has cavities, doesn't go to the dentist. And tend to have delayed physical development. This leads to behaviors of begging and stealing money or food. Kids that are begging or stealing money or food, that's a cry for help, folks. Extended stays in school. They arrive early and leave late. They're avoiding it. Sometimes they get meals after school. Sometimes that's going to be the only meals this kid gets. Frequent tardiness or absenteeism because the parents don't care. They don't care if you go or you don't. Alcohol or drug abuse, especially at a young age. You know, if you've got a 12-year-old kid that's drinking and smoking pot, they learn that somewhere. Or if you ask them, hey, where's your mom or wherever? Well, they're not here. They're never home. I never see them. Parental behaviors, alcohol and drugs, disorganized, chaotic or upsetting home life. They're apathetic and feel nothing's going to change no matter what they do. They tend to be isolated from their family, friends, and neighbors. Oftentimes have long-term chronic illnesses, history of neglect as a child. They tend to expose their child to unsafe living conditions. And the biggest parental behavior and neglect is you can't even find them. So our action is document, treat the patient, collect significant items. Sorry, folks, I'm trying to hurry it up a little bit. Here's the key. You adhere to mandatory reporting requirements. You are all mandatory reporters. You have to report this abuse. This is not a choice. You need to interact with the appropriate agencies and get that done. Do I have a question?
Matt, I just want to make a point. This is interesting, that the number of reported cases of child abuse decreased with COVID. Okay. And it's interesting because, you know, then people want to speculate and say, you know, well, why was that? You know, well, and I'm not sure if, you know, people figure it out, but as you said before, it's that these kids aren't going to school, they're not going to daycare. Right. And the teachers and the daycare workers are mandatory reporters. So therefore, it wasn't that the incidence of child abuse decreased. Actually, the incidence of child abuse increased, but the number of cases decreased because the mandatory reporters weren't seeing these kids. So that's huge. You know, and again, I want to emphasize again that EMS, you are mandatory reporters. So if you see something, you are obligated by law to report. That is key.
Thanks, Joe. I'm not going to go all the way through human trafficking. I'm just going to show you this one little stat. And then I'm going to let you guys go. According to the National Human Trafficking Hotline, Ohio had 450 documented cases of human trafficking in 2019. During that same time period, the Ohio Task Force states that they estimate 3,000 Ohio children are at risk, and about 1/3 of those are likely to end up in the sex trade. That's heartbreaking. Human trafficking is exploitation based and does not require movement across borders or any other type of transportation. Ohio ranks in the top 5 states for human trafficking, no matter how you slice it. If you suspect human trafficking, transport the patient alone. Do not allow the companion to come if you can help it. Ask the patient to turn off their cell phone and watch them as they turn it off so that no one can listen to the patient during transport. Share concerns privately with other emergency personnel and the ED staff so that they understand the sensitivity of this situation. And if the patient is a minor and refuses to be transported, call law enforcement. Call law enforcement anyway. Call them anyway. So mandated reporting. You are a mandated reporter. That means you are required to report any and all cases of suspected abuse or neglect of a child, the elderly, or infirmed, even if you are told that it has already been reported. Here's a couple of phone numbers. Elder abuse can be reported to your local adult protection service or by calling the Ohio Adult Protective Services. Child abuse can be reported to your local Department of Jobs and Family Services or by calling the Ohio Department of Job and Family Services. Human trafficking should be reported to your local law enforcement or by calling the U.S. Department of Justice Human Trafficking Office at the numbers that you see there. Ohio is huge for human trafficking. You need to keep your eyes open for it. Again, that doesn't mean people sometimes tend to believe that human trafficking means that you're taking them around. That's not what it means. This is forced prostitution and all of those terrible things that we see. We see these people every day. Okay, do I have another question? I see a hand up.
Hey Matt, it's Justin Boley. Yeah,
okay.
I had something to the human trafficking in Ohio. Interesting to me is, as you know, me and my wife spend a lot of time up Ottawa County, Toledo, East Harbor, Port Clinton area, and Toledo is one of the worst places in the whole country. But every person that works in Ottawa County, because I talk to a lot of people up there, no matter if you're a public employee or not, I'm talking people that even work in private business. They have to go through a human trafficking class there because it's so prominent up in that northwestern part of Ohio to be able to recognize it as Walmart employees, as convenience store employees, as state park workers, people not even in the law enforcement EMS side or medical side of things, which I found very interesting because Ohio is such a high-ranking state for that, which I was not privy to till the last couple of years.
I think that's great. The more eyes looking out for these vulnerable people, the better. Thanks, Justin. Is there another question out there?
Hey, it's Ralph. I'm just curious, and I know I've probably heard this in the past, but what is it about Ohio that makes it so prevalent? Is it the access to the north, the access to the highways to get them to big cities? Like, what is it? And what, like, specifically, maybe that last person that just spoke could say, like, about Toledo that makes it that?
Hey, Ralph.
Is it? Yeah.
Talking to those people up there, because I actually talked to a few state employees. What it is Ohio's kind of dead set in the middle of New York and Chicago, Detroit. We have 70 major highways, but Toledo is a big interchange for Detroit, Chicago, Pittsburgh, Cleveland, New York City, and then down to the south, there's a big cross highway there. And that's one of the main reasons Ohio is such a hotbed for it, to getting people moved around the country and even out of the country, from what they were telling me. I'm no expert in it. This was just kind of going down a wormhole talking to some people up that way.
Okay, thanks. That's kind of what I figured and what I'm sure I probably heard in the past, but I was, I just wanted to hear it again. So thanks.
Yep.
Thanks, guys. Do I see another question out there?
I see John Guy raise his hand, but I'm gonna jump in before John. Just want to make a point that human trafficking is not just sex trafficking. That's one component. Human trafficking could also be labor trafficking, or so it's not just sex. It could be labor, where it's not trafficking for a sexual reason, but it's trafficking for labor purposes too. So just keep that in mind. May not just be sex trafficking is a part of it. Human trafficking is the umbrella. And then you have sex trafficking and labor trafficking too.
That's very true. Slavery is actually a very real thing in the United States, especially in the farming industry, and from what I've read in the horse racing industry, believe it or not.
Yeah, real quick, let me jump in here. Yeah, I was going to bring that up, Joe, as well, because of our migrant workforces and stuff in this area, and horse racing and other things. Yeah, labor is definitely an issue. And just to add to more what Justin said, my wife's in the hospitality industry, works in a hotel, and they mandate that they go through human trafficking courses because of the propensity to move from non-residential communities to use the hotels as places to stay and keep on the move.
So it's Ralph again. So what specifically is it about horse racing? Just the fact that they move around, or is there something in particular?
The one thing I read about, it's almost like indentured servitude. Again, they victimize like we were saying, mostly illegal immigrants. They victimize them and make them take care of, a lot of times people travel with several horses to several different places and whatnot, or horse farms or just regular farms, Ralph. And what they do is they take all of their identification off of them. That's why I had to skip some parts of this lecture. That's one of the main things they'll do. They'll get their identification off of them, so that they can't go anywhere, so that they can't get away. They don't have their green card or their passport, or if they had any of those things. That's what makes them vulnerable. But the horse racing industry is very much immigrant driven, and that's what makes it susceptible to it.
Yeah, that's pretty interesting. Thanks.
You're welcome.
I have a question for the local area.
Okay.
Besides calling like I've called the police in the past for elder abuse because the hospital blew me off. Is there someone inside the hospital at Lake St. Ease or Trumbull that would be someone to grab in the ER that will pursue it? Because calling Adult Protective Services is intimidating, but trying to get a social worker in an ER sometimes doesn't happen, or they do blow you off. That's why I ended up calling the cops before. And Austintown PD did an amazing job, but the hospital not.
Well, the hospital should have social services, social workers, and they're going to be trained in this type of thing. Nobody should be blown off. Just like you're a mandatory reporter, so is that person that you talked to in the ED. And if you reported that to them and they didn't take it up the line to where they should have, then they're as much. Yeah. That's not right. I've had the best success over the years with going through the police department for abuse, but also had the advantage of we had a really good working relationship with our police department, so that made it easy. I've also my experience with going through social workers at different hospitals has actually been very positive. I call the next day and I'd say, hey, I need to talk to a social worker that deals in child abuse. I brought in a patient yesterday, and you'll get somebody. You'll get somebody. If you have any problem, with Trumbull, I'm your next call.
Right. Right. And I think we are more, it's easy to talk to the police that we work with, be like, hey, I was on this call earlier. This is what happened. But I know the hospitals are crazy. So it's harder to get somebody.
Okay. Well, if you have any problem with Trumbull, you let me know.
I will.
Thanks. Any more questions out there?
Matt, just one other thing. Actually, my wife was here listening to this, and this is her area of expertise, the child abuse. And she was saying that as a mandatory reporter, we used to teach students in the past, and I quit teaching them, is actually after Anthony Paloli became a law enforcement officer, and we were doing a continuing ed, and he was like, no. You're a mandatory reporter by the Ohio Revised Code. And I know that's my wife said in the case of child abuse, by you telling the physician in the hospital or the nurse in the hospital, that's not good enough. You are the mandatory reporter. And so just be careful, because this could come back on you, being an EMS, because if you say, well, I told the physician and I thought the physician would do something about it, that doesn't alleviate you from your responsibility of being a mandatory reporter. I don't know, Lauren, about I'm going to ask my other daughter, and I'll get back with you, Lauren, on that with the elder abuse, because I don't know, but I know with the child abuse, my wife is saying specifically that you are the mandatory reporter. And if you tell somebody else with the expectation they're going to tell somebody, it does not alleviate you from your responsibility.
Well, thank you, Joe. Like I said, we told the police and the police took care of it. It worked very well. But
So, Joe, does that cover if we tell the police? Are we covered by the Ohio Revised Code?
Yes, if you tell a police officer, you are covered. So that is so what you're saying, Lauren, is actually appropriate. That your alternative is call the police, or Ralph, you call the police in a child abuse case. Yes, that is then appropriate for you to do. Yes, you are then alleviated of your mandatory reporting.
Okay, thanks.
And if you report it to law enforcement on the scene, make sure you document the heck out of that. That hey, I told Officer Smith, da 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 da.
So, Joe, on that same subject, this is Jenna Rendis. The documentation for, say, we had a 2-month-old that had an injury that was realistically the story that the father had told could have happened, but the father's story changed a few times and it just didn't seem legit. A month later, that baby ended up dead by the hands of the person that we thought. And so on my documentation with the initial report, I just put that the stories kept changing from the people that were there, because the injury to the child at the time was very minimal, but it just didn't feel right. So I try to document it the best that I could without being judgmental or biased, because if it ever goes to court, which it definitely will, is that all you can do? I reported it also to the people at the hospital, both the doctor and the nurse. But at that time, it wasn't a significant injury, and it was the first incident. So, is there anything else we could do better on that?
That's a tough situation. But as far as documentation, your PCR is obviously, and again, Matt can tell you more about what his expectations are too, but your PCR is really for medical treatment being provided to the patient, and it's to document objective information about the patient, their injuries, their medical illness, whatever it would be. So your diagnostic finding, your assessment finding, and so forth. But you know what, Jen, there is nothing ever to keep you from taking a legal pad when you get back to the station and just writing yourself the notes, what was said, how the parent was acting and so forth. And that is exceptionally helpful when you go to court, because these are things that they're going to ask you. And again, these attorneys are slick. I've done quite a few expert witness cases, and their whole intention is they really don't care about what you have to say. All they want to do is try to discredit you. And that's why, the deposition you do, boy, you have to study that deposition, because if you go into court and they say, they ask you the same question 10 times, and if you trip up on that, then they immediately, it's like they go on the attack to discredit you. So that's why it's very helpful that for you to say, instead of saying, well, I recall 5 years ago, versus saying, well, let me refer to my notes I wrote down, an hour after the call. Well, it says that the patient did this. It says that the father was acting this way. The father did this. And that is solid. That's exceptionally helpful, not only to you, but it's exceptionally helpful to the case where that's all captured. Because I'm telling you, they're going to make you feel like so good about yourself. Like you run all these calls and you're so busy, and they're setting you up to attack you, to say, how in the hell could you remember 5 years ago, 3,000 calls ago about this particular case? Then you start second guessing yourself, but always feel free to write your own notes. And like Matt said, if you did the incident report, they'll tuck it away for you, just again, make sure it's dated and it's signed, because if it's not signed or dated, then they'll say, well, prove to me that those are your notes, so that's the only thing I say. And it's sad. It's sad cases.
Thank you.
Joe, I wonder if you should have a supervisor sign that also, just to prove that, like almost like a notary, to prove that was the day that it happened.
Well, you know what I would do, Ralph, instead is I would have whoever my partner was sign it, because they were at the scene with me. But I agree with you, have another person. So my wife actually called my daughter, who's an LASW, and about the elder abuse and so forth. And she said the elder abuse is exactly the same as the child abuse. So Lauren, you calling the police is the right thing to do, because she's saying that you are the mandatory reporter. So by you telling the doctor, the nurse in the hospital, you are still the obligated mandatory reporter in an elder abuse. So again, contacting the police is the right thing to do, Lauren.
Awesome. Thank you.
Very cool. Good conversation, guys. I appreciate the participation.